Hello everyone, a very good afternoon. I, Kanchan Maurya from Cipla marketing team, welcome you all on behalf of Focus in and NEFCO Academy. So, welcome to all the participants on behalf of NEFCO Academy, which is focused on Neonatal Focus Eco Academy. Today, our topic of discussion is Neonatal Lung Ultrasound, which is an interactive lecture with live demonstration on NICU babies by neonatologists trained specifically in focus. With this, I like to welcome our NEFCO directors, Dr. Mohit Sahani, Dr. Kiran More. And our esteemed faculties for today are Dr. Surjit Kaur Madan and Dr. Anup Thakur. With this, I like to hand over the session to Dr. Mohit Sahani, the director of NEFCO and Focus. Over to you, sir.
So, good afternoon, everyone.
Good
Welcome
afternoon.
to this session. There is a bit of confusion because here there are few people have been shared with the presenter link and other people have been shared with the viewers link. So in total, almost 95 people are here. Yes, so it is good that we have a faculty of 95. So that is something very encouraging. So almost 100 people here and around 250 or 300 people on the other side. So I am really thankful to everyone for joining in. So this is around, I will just give you an outline regarding our academy, our faculty for today, and the outline of the lung ultrasound workshop, this CME. First, you can all ask, you have a question that why it is being concentrated only on lung ultrasound? Like our NEFCO Academy, under that, from the last 2.5 to 3 years, we have already completed 6 batches running almost 3 years. Myself and Dr. Kiran, we have been running this academy. So here we do 6 months of focus course. So in the focus course, we include lung ultrasound, head ultrasound, abdominal ultrasound, and the majority part is the neonatal echoes. So in that, we have seen like few people, they have very targeted approach. So that targeted approach is they just want to manage their ventilation of the newborns. So in that, the most helpful thing is the lung ultrasound. So that's why now the people have further divided the focus and divided into subgroups like neonatal functional echo, lung ultrasound, and separate head ultrasounds. And then some people just want to do the central line insertions, abdominal ultrasound care. So that kind of thing that have been merged. So that's why now after 3 years of 6 batches, almost we did crash courses and many things, almost more than 1,000 people have gone through this, the learning of focus, neonatal echoes in last 3 years. And they have been attached to this, our NEFCO family. And we have Dr. Kiran More along with us. So he has been doing this under the banner of Focus In. So now basically Focus In and NEFCO, they are the sister concerns, and we have been doing this. So in today's the CME, you will be going through, we won't go in very detail, but there will be a touch of everything that is needed in the learning of the lung ultrasounds. So, just a second. So in this lung ultrasound CME, we will be doing an introduction with some, kind of outline of the principles of the basic ultrasonography, because that is something which is needed very importantly, and that will be done by Dr. Kiran Moore. So he is one of the directors for NEFCO Academy. And Dr. Kiran, welcome. And he is being the pioneer, and he is my colleague from last many years. He is being trained in focus and neonatal echoes from Australia, Sick Kids, Toronto. He was a consultant in New Zealand and then at Doha. And now, fortunately, we have him with us in Mumbai in MMR hospital, which is a state-of-art hospital. And he's been doing this for many years, and he was a consultant in Vadia, and he has started this program in Vadia. So Dr. Kiran, welcome. I would request people to please don't annotate. Keep your mics mute and somebody's annotation is on. So I would request, please um, uh, don't start your annotations. And then we have with us Dr. Surjit Madan. She is a consultant neonatologist at Jalandhar, and she has also become a I would now she is one of the faculty with us, and she was our first student for batch one, and over 2 to 3 years she has transformed and she did further courses in lung ultrasound, and now she is the one of the major core member of our lung ultrasound team. And welcome, Dr. Sujit, for today's
Hi.
CME.
Yeah, good morning.
And then we have Dr. Anoop Thakur with us. Dr. Anoop, are you there?
Yes, I'm there, sir.
Yes, Dr. Anoop is there. So he is a consultant at Sir Gangaram Hospital, and he's also been trained in the lung ultrasounds and POCUS, and he has been running the courses in lung ultrasound and the whole POCUS and neonatal echo. So he is my old friend, and he has been involved with me from the last many years, and we have conducted a lot of eco workshops. Until now, we have already conducted around 82 eco workshops in last 14 years. So he is a part and parcel of our team. And his knowledge about lung ultrasounds make it unique. And once you will listen to his talk, you will realize that. So welcome, Dr. Anoop.
Thank you, sir. Thank you for the introduction. Thank you.
So for you today, we also I am going to announce this. So we will be coming up with our exclusive neonatal lung ultrasound course. That will be the course certified course for 3 months, and it will be starting from 9th May. And then in that we will have a renowned international and national faculty. So these are the whole details. Like there will be two versions of the course. One version is online, pure online for 3 months. In hybrid, along with this online, we will have 2 days hands-on training in NICU level 3 units in three places in India, in Mumbai, Surat, and Jalandhar, in rotation. So those who are interested, you can either inquire on this number, which is being there. You can take the picture, or you can put a email. You can give us the WhatsApp message, or you can register for this course by scanning this QR code. So these are some details on which you can inquire, and you can register by scanning this QR code. So I've already told you regarding Dr. Sujit, Dr. Noob, and Dr. Kiran. So I've been receiving some calls. I think so. This 100 capacity of this facilitator, this thing, faculty link has been over, I think, and now people who has got link may be calling this. But no issues. And then we
You
have
can ask them to
100
log
people
in
here
from
and 410
yeah,
people on the sites.
yeah, they can log in from the delegates link.
Yeah,
No?
I will be doing that.
We can share that link
Yeah,
in
yeah.
the
So almost
this
100 here
chat
and
box.
400. So almost more than 400 people have logged in. So now the next thing is we will start with, without losing any much time, we will start with Dr. Kiran. He will be talking about principles that are being involved, because everybody should know the principles of ultrasonography before starting doing anything. So you all Dr. Kiran, you can start. And this is very important lecture, because until unless we know about the basic principles, it is difficult for anyone to understand why we see what one particular signs in a lung ultrasound, why we see A lines, why we see B lines. It is very important. And for the interpretation of that, you should know your basic principles of ultrasonography very nicely. So over to you, Dr. Kiran.
Sure. Okay. Let me slide my slides.
And for everyone, those who want having any doubts, any questions, any queries, any comments, you please keep putting in your chat box or your question and answer box. So at the end of every session, we will have some time to answer by the relevant faculty. And in the end of the CME also, we have a provision of some time for answering your questions. Thank you. Over to you, Dr. Kiran.
Okay. Thank you. Thank you, Dr. Mohit, for nice introduction. So, good afternoon, everyone, and welcome to this ultrasound CME. And we all are overwhelmed with the number of registration. We had almost 1,800 registrations, and already we are beginning, and we have more than 400 people live. So that's very exciting, and I'm hoping more people to join and more people to get benefited. So I'll begin with my talk, which will be very brief, probably with 20-25 minutes. And my role is very simple, to take you through a little bit of basics of the ultrasound, maybe physics and knobology, and some other principles which will be relevant for the lung ultrasound. And then from there, we'll take on Dr. Sujit will talk about the basic patterns, and then Dr. Anup will be showing the pathology, and Dr. Mohit will do the demonstration. So, as Dr. Mohit said, I was feel very fortunate to get training under different countries in Australia, Canada, and then also we started different programs in Qatar and in India. And as our academy is growing, and our almost more than 400 people now so far has been, in some form of in touch with us. And basically, the family is growing with more and more people doing point of care ultrasound, and I can see the enthusiasm is a lot in the current generation, especially those who are doing residency or DNB, DM, or fellowships. So very nice to see. My goal will be, as I said, will be basics. I'll be talking more of the artifacts which are relevant to the lung ultrasound, some basics about the probe, and some basic principles. So, lung ultrasound is a very now become an integral part of the POCUS, the point of care ultrasound. But historically, the lungs were considered as non-explorable due to their aerial content, because it reflects the ultrasonic waves. So it was always thought for a very long time that you cannot scan lungs because they're filled of air. And only the superficial pleural conditions like tumors, effusion, or maybe guiding like a biopsy or a effusion or tapping something, the lung ultrasound was used. But then there were more passionate clinicians who actually explored lung ultrasound, and he's one of them. Anyone knows his name? I think his name,
Daniel
everyone.
Lincolnstein.
Yes.
Lincolnstein, yeah.
Lincolnstein, yeah, it's very right. So, and in fact, I feel very fortunate that I did my first training with him in Switzerland, and I have never seen a passionate person for lung ultrasound like him. He'll demonstrate on his own body, and he'll create his own artifacts, and whatever the science we will be talking, Dr. Sujit or Dr. Anup will be explaining. Those are his majority of those were his imagination, and you have to train your brain and eyes to imagine those signs, because lung ultrasound is all about identifying the artifacts and imagining those signs which are pathognomic of certain conditions. So he was the pioneer, and that's why rightly called as father of lung ultrasound. And in 1990s, obviously first attempted was made for RDS, but I think from 95, Dr. Lincolnstein introduced this thing, and how to diagnose pneumothorax, pleural effusion, RDS, TT, and all those things. He started from adults, pediatric, and went on to the newborn. So everywhere, all those signs are actually are applicable in all the fields, in fact. And he decoded those artifacts, which are created by the pleural line and the air content. So basically, again, lung ultrasound is not scanning the lungs, but it's decoding the artifacts, the reverberating artifacts which are created by the pleural line and the air content in it, whether there's a fluid or there's a free air. So it has definitely has evolved now. More and more your use cases are there nowadays, and it is becoming more popular because it's one of the easiest modality to master, very easy to learn, rapid curve. Within like a week probably you can learn. If you have a unit full of patients, then you can just go over 1 or 2 days and learn all the signs possible in lung ultrasound. It is quick and reproducible. In fact, there are obviously comparative studies are done. The signs done by different people, they are generally reproducible as compared to the echo and the other lung ultrasound, where it's quite user dependent. Here it is very easy and ionizing as so no need of X-rays or repeated X-rays are required, and it is independent of the acoustic window. So it is very feasible in most of the clinical scenarios, because you will not have unless I mean in diaphragmatic hernia or some other content in the chest, it will interfere. But most of the other situations, you will get some sort of windows, acoustic windows to scan the lung. And in neonatal care, obviously it is now extensively validated, especially last 10-15 years. You will see lots of publications are coming up. In fact, we were also planning one of our studies which is underway, and but obviously there are lots of studies related to RDS, TTN, and other relevant anomaly pathologies. Sphenic and other most many guidelines are suggesting that it has to be used in critically ill neonates, but it still remains underutilized, and chest X-ray remains still a go-to modality at many places. But even in the busy places, I see that even getting an X-ray, if you don't have a digital X-ray, it takes time. But lung ultrasound just take a minute or two to scan. So it's a very useful modality to learn, and it is part of the crashing neonatal protocol, which is applicable even to a crashing child protocol. So a child with unexplained deterioration or a newborn with unexplained deterioration, this crashing protocol of POCUS is very important, where you quickly do the echo, few findings in the echo, lungs, see there is no effusion or pneumothorax suddenly, bleed, and abdominal POCUS, and lung ultrasound becomes a part of it. I'll just quickly go over a bit of a physics, especially for those who are not been trained with ultrasound for any modality, some basics to know. So ultrasound, as name suggests, it uses sound principle. So it uses sound waves, and it uses the sound in that ultrasonic frequency. So what is ultrasound? Means this the waves which are in a very high frequency, which human ear cannot perceive. So normally human ear can perceive only 20 hertz to 20,000 hertz, 20 to 20. So this is the range of the audible frequency a human can hear. Anything beyond that is your ultrasonic sound. So very high. And good that we don't hear those ultrasonic sound. Otherwise, if the echo machine is operating, somebody is operating, and you will hear this sounds continuously, it will be disturbing for the baby and us. So good that we don't hear. And then there are this infrasound also, which only certain mammals like elephants can hear. Ultrasonic waves, bats can hear, but we cannot. So these are the echo frequency between 2 and 12 million hertz, or 2 to 12 megahertz. So that's the frequency, and that's the frequency of the different probes which we will be using and which we will be talking about. So I think the origin of, of the ultrasound physics actually came from, as learned from the animals, how, scientists explored how bats might be exploring or catching the prey in the night. So that's your echolocation. So basically, as you might be aware, the bat sends out the ultrasonic waves, and in the dark, and if the ultrasonic waves hit the prey, the reflection comes back, which the bat will appreciate and can actually detect the location of the prey and go and catch even in the night. So that's kind of the principle which is used. And sound waves, these are the sound waves. Basically, they travel in air, and then they change in the different media. But basically, they are best represented by a like a sine wave. So you can see they're like the sine waves, where the height of the sine wave is your amplitude, and the wavelength is the distance between the two waveforms. And so you might have a sound wave which has a higher amplitude and a higher frequency, like this compared to this. So you can change the amplitude and the frequency based on the probes you used, and based on that, the penetration into different organ will vary. And so you might have a shorter wavelength which will give a high frequency sound. So basically you can pack more waves in a shorter distance, or you might have a long wavelength, which will be a lower frequency wavelength like this. So the range of the frequency it varies, and what does that mean is frequency means the number of waves of cycle per seconds. So how many waves you can fit in 1 second, that's your hertz. So it can range from 1000 hertz to 1 megahertz up to 12 or 20 megahertz, which are the ultrasonic range frequency. So more the frequency, better the clarity of the images and all those things we'll quickly talk about. But this is what the principle of the sound wave is. Again, so this sonar principle or the ultrasound principle has been utilized for many years by simple technique like your radar. So your sound wave is propagated from this radar or a sonar they used to call, which and once you have a submarine or something going underneath trying to attack the ship, then this sonar will reflect and then the object will be detected. Same thing will be is used in the radar principle, where the transmitter is actually emitting the waves which will get reflected by any plane or any target which is entering that zone, and then the reflected waves will come back to and will be received by the receiver. And then obviously the you see in the movies, those planes will detect, okay, the plane is approaching. That's just based on your sonar or the radar principle. So similar principle is used in actually the ultrasound. So here what we are doing is the transducer generates ultrasound waves. So there is a way it will create those high frequency waves. Once you held those, you hold the probe in a particular position. Suppose you want to do a echo or a head scan or a lung scan in a particular area of interrogation, you will hold that probe, and basically these sound waves will travel from this probe into the tissue and then the fluids. And obviously when they enter the body will react or interact with these waves. So some of the sound waves will be reflected back, some might propagate further and they go deeper, and some will come back. And basically as the waves come back, the transducer will receive them and then carry the signals into the echo machine. And depending on the differential of the reflection, the image will be created. So some waves will be reflected quickly, some will take go further and reflect depending on the what is the density or what is the consistency of the tissue it is entering. So bone will reflect differently compared to the soft tissue, compared to muscle, compared to blood, compared to air. All those things will vary, and we talk more about this relevant in echoes and ultrasounds and the head ultrasound. But for lung ultrasound, you don't have to worry about all this, because there we are just recording the artifacts, and I'll come to that shortly. And what creates these sound waves is something you need to know. And there is a it's called as piezoelectric crystals. So there is a piezoelectric element which is the core of the transducer. And you can see all this. This is the transducer. All these squared crystals which are packed at the tip of the transducer, and these are the ones when you turn on the machine and electric current is passed into these crystals. These crystals will start vibrating, and there are these thousands of these crystals which are there in the part of the ultrasound probe, and then they vibrate and they produce a very large sound ultrasound waves. So that's the core principle, that it uses piezoelectric crystals which will send the ultrasound waves, which will go into the body, will reflect, refract, interact with the body. They come back. The same probe will receive those signals reflected back, and will create a computer an algorithm will compute an image. And how these crystals are arranged will decide your types of different probes. So everyone people ask us, sir, we want to buy a new machine. Is one probe enough or two probes are required? How many probes we should buy? So there is a reason why you need more probes, because the way these crystals are arranged, the way this array of this crystal is there, will decide how the organ will be visualized. So there are certain areas. So a lot of time you need a phased array in newborns, especially because you have a very smaller window. Already the chest is small or the AF is very small. So you have a smaller area of window to enter the body. So you need a probe with a smaller footprint and allowing image through us, like in even for the lung or for the heart, you have to scan through the intercostal windows. So the windows are very small, so you need a phased arrow probe where through a smaller window you will get a wider range. But for certain other scans like bigger organs, solid organs or heads, you might want a wider range again and a deeper range. So wider area needs to be covered. Then you need a curved array probe or a linear probe. So for the lung ultrasound, I'll coming to that. You need a array such that it is capturing those certain zones. So you need a preferably a linear array probe. So the arrangement is different. So that's why you need a different echo probe for a head scan and different to the echo scan and then different for the lung scan and a bit of different for a vascular scan, because it is how you want to visualize the structure, and that is based on the arrangement of these piezoelectric crystals in different probes. So best probes for the lung ultrasound, which today we'll be talking, will be, I think, the hockey stick probe. I think we all love hockey stick probe. If you have it, that's very good. It's a vascular probe. This is how it looks. And you can see this a linear footprint is there. Even for the smaller preterm baby, it is easy. Around 15 to, it's a high frequency, this thing, 15 to 18 megahertz. And yeah, for even the preemie or the term babies, it will be utilized. Or if you don't have that, you can use the linear probe, which is 5 to 12 megahertz. So this is a linear probe, also can be used. Curvilinear also can be used. In fact, that's the beauty of the lung ultrasound, that you can use any probe, in fact, for that matter, as long as you have a proper settings or the presets. That's very important thing, and that's the mistake even I did when I came back after learning from the father of lung ultrasound. I came back and first 2 3 months I got really frustrated. Why I'm not getting, he was showing all the signs so nicely. I'm not able to visualize, and I feel lung ultrasound is very hard. And only mistake I was doing was we did not do the presets. So I think having a proper presets of lung ultrasound or musculoskeletal preset. So most of the machines will have a you will have a MSK preset. So MSK is musculoskeletal presets. So if you have MSK presets, then you will be able to capture those artifacts, and that's very important to know. So any probe, preferably linear probe or hockey stick probe, and higher the frequency, better is the picture, because you have a better resolution. So it's like a higher frequency is like your 4K TV or a high definition TV, where your resolution, the clarity is very good, so the pictures are better. Now, the regions and lung partition, Dr. Surjit will be talking, so I'll not cover. But basically, this probe, you must put it in different areas. You have a 12 region approach or a 6 region approach, and you put it either in a perpendicular probe position, which is most commonly we used. Then you see you cut the ribs and pleura, everything, or you can put a parallel probe position also, which again more details to follow in the subsequent talks. So use the linear probe, put it in the with different zones, and then you identify the artifacts. So again, those detailed artifacts will be covered in the next lecture. But what I'm trying to say is the principle of a lung ultrasound is you put the probe and you try to get your at least the ribs visualized, the dark shadows coming from the ribs which are visualized. You visualize the lung which is moving, and then you clearly visualize the dark pleura, which is a sharp and bright object. And then whatever will be produced below will be the artifacts. So these are the artifacts which are produced, which will form different patterns, A lines, B lines, etc., which we'll cover in the next class. But basically, you are just trying to generate these artifacts from the ribs and the pleura, and you have to identify the subacute tissue, muscle, and then the pleura. And then suppose if you put certain specific modalities like M mode, then you will create certain patterns. So that's kind of the basics for of the lung ultrasound. Now, because we are talking about artifacts, I'll just quickly go through some of the artifacts and okay, I'll take 5 more minutes and I'll stop. Okay. So in artifacts, as I was saying, uh, as the as the lung ultrasound waves are entering the body, they're entering the skin, subcutaneous tissue, and there will be a different tissue phase. There might be a bone, there might be a like a liver capsule, there might be like in lung there is a pleura, and there might be still a pericardium on the left side. So all these things, what will happen is some of the waves will be reflected going backwards. Some of them might just change the direction, which is called refraction. Some of them will get attenuated. That means as they go inside, their frequency or their strength goes down, so they get attenuated. So they are initially very far, very much like compact waves, and then they get attenuated, and then they will penetrate less. Some of them might get scattered or absorbed, and that causes sometimes the dark shadows. So if the veins are, if you're not in a correct window, the and something deeper inside the tissue is interfering, the veins will get the ultrasound waves will get scattered or absorbed, and then you get a very dark sort of acoustic shadows, and image will not appear very good. That means your window is not correct. Find a new window where you get a more clarity. So scattering absorption will distort the image. The reflection is something which creates the image, so that's important for all other focus, not for the lung. So because the reflection will create, but important to know that, so the sharper objects like pericardium or the diaphragm or the liver will reflect more, and you will get a more sort of sharp margins. And now in lung ultrasound, important that the pleura reflects the reflects is more than anything else, and that's why you see the pleura appearing as a sharper line there. And then the refraction, as I was saying, that again not much so relevant in the lung ultrasound, but there is basically some attenuation of the waves. They are going in one particular direction. There is sudden change in the interface, like from bone to tissue or tissue to fluid, and the direction of the sound waves will be changed, and sometimes it creates certain artifacts. Sometimes you start appearing new objects which are not there, or the new vessel. There are two aortas will be seen, something like that. That will happen because of the refraction. And attenuation, I was just saying that the principle of attenuation is only relevant because we'll be talking about the depth and the frequency. And as we said, we need a higher frequency probe for lung ultrasound because we are just capturing the artifacts. But higher the frequency, better is the resolution, better is the clarity. But higher the frequency, more is the more is the attenuation. So what does that mean? If you the higher frequency waves entered, they get quickly they lose their frequency quickly, and they don't go deeper. Like you get it in high frequency ventilation, you have a lot of attenuation. If you don't have a rigid tubings, the attenuation is too much, and the actual map will not be reached. Similarly, higher frequency waves have more attenuation, loss of frequency, so though they don't go deep. So if you want to go deeper, suppose you want to scan something in the lung which is deeper, fluid or something in the posterior mediastinum, then you need to use the lower frequency, because lower frequency probe, which is like this, will have a less attenuation. It will go deeper compared to this high frequency. So that's why in the preterm babies, you can use higher frequency probes because that chest wall is thin and the penetration is easy. But in a bigger babies, thicker chest wall, older babies or children, you have to use the lower frequency waveform so that they penetrate better. And then comes the last, the reverberation artifacts. And these are the artifacts. Basically, they are generated by the strong reflectors such as ribs, pericardium, or pleura for that matter here. So those are the reverberating artifacts which are the created by the reflectors in the body. And so there will be some additional reflection within the tissue before they returning to the echo. So now these lines are not there. There's nothing in here. There's no pleura. But these are basically artifacts, layers of artifact which are created within that lung tissue because of this reverberation phenomenon. Like here you can see that there's one this thing vertebra or something, but there's a linear reverberating shadow which is created. See how this reverberating shadow is created, and you will see that there are these multiple lines which are there, but they are just artifact. So here also this is like a combat artifact. So there is a some sinusoid or something there, and then this comet-like artifact which is created. So you will see all these patterns which Dr. Sujit and Anup will be explaining. These are comet-like artifact because the ultrasound waves are passing like this, and there's a shadow which is created like a comet, and it's just an artifact. So whatever comes, and waves take the direct path of the tissues, and then they come back with this reverberating, and this is called as the. So there is a multiple images behind this reflected, which is the comet tails. So comet tails and these multiple lines, which are the reverberating artifacts. Now, some basic principle which you always talk about, be gentle with the lung. Ultrasound doesn't take long time, so be gentle with the baby. Make sure the baby is settled, not moving, not crying, because crying or high frequency ventilation or other things will interfere with the sound waves. So make sure the baby is comfortable, temperature is okay, and you give some sucrose if you have, and hold the probe like a pencil, or sometime this is a way, whatever way makes you comfortable, and position the patient. Make sure you're comfortable, patient is breathing, and then we'll talk quickly about the novology. I'll quickly skip through. Uh, yeah, be yourself. I mean, lung ultrasound again takes only 5 minutes, so you can do standing also. But if you're doing something else along with it, then make sure you are comfortable. Position of the machine is very handy. So your left hand is free for the machine, and right hand is on the baby. And make the room darker so that you get better clear images. Dim down the light. Turn off the phototherapy. All those basic things you do, and then few knobs you need to know, which again Dr. Mohit will show you. But anyone using the machine for the first time, it's like riding the plane. Pilot needs to know all the knobs. So you cannot say that I don't know this machine, and then you cannot actually store also, you cannot acquire. So knowing the machine is a very basic thing. So call your application specialist or company person, go over all the knobs which you require. This is kind of a basic sort of layout in most of the machine. And you need to know the different sizes of the probe, frequency of the probe, which will be you will be scanning. So preterm and term, there might be different probes and different frequencies required, so you should be aware of that. And the first thing, when you put the probe on the chest, you adjust the depth. Many times you will see like this is the echo image, but in the lung ultrasound also you might just be too superficial, so you will only see the subcute and the ribs. So you have to adjust the depth as the first button, which will take you deeper inside the lung. And so the depth button you should be aware of. And all this scanning you will be doing in the 2D mode or the B mode. So you click the B mode, then you adjust the depth, then you adjust the gain. Again, gain is like a contrast, like these older televisions we had, the black and white television, where you have a contrast button. So you adjust the sharpness or the color contrast, the black and white contrast in the 2D mode. So if it's too dark, like here, you will not be able to see. And if it's too bright, then also you will see lot of artifacts and lot of shiny sort of images, which is not good. Again, Dr. Mohit will demonstrate you. It's easy to show on the machine how the depth is adjusted, how the gain is adjusted. And there is something called as gain compensation. So all the whatever you're scanning, the triangular zone of the scan can be divided into different zones, which actually corresponds to these knobs.
Just a second, Kiran.
Yes.
Some people are telling that nothing is audible,
Oh, really?
but we could. But yeah, no, it is okay. But we can hear. I can hear you very well
Maybe I
and
think
see
network.
all the
Dr.
slides.
Surinder. Yeah.
Yeah, it may be issue on the other side. Yeah, yeah. Please carry on. We have another 1-2 minutes. We have to finish.
Sure,
Because
I'm done.
already.
Correct. So I'm almost done. I think some questions are there. Correlation with the X-rays and all these questions will be answered in the subsequent talk, where we will talk about the pathology. This talk is just focusing on the basics of the ultrasound. So just like touch basing with the basic principle, which people were not used to using the machine for them. So time gain constant again is like adjusting the your gain in different segments of the scanning region. So there's a gain button which adjusts the contrast for the whole screen, but you can adjust the contrast for each and every zone based on these knobs which are provided in the machine. Again, Dr. Mohit probably will demonstrate that. So you can adjust the knobs the way you like, and the whichever area you want to highlight, you will move these knobs toward right side to make it more brighter. So those zones can be changed relatively based on these knobs. And last but not least is the M mode. Again, very important for the lung ultrasound, because again there are these different patterns which will be producing. So there's M mode button which you can turn on and off, and it will give you a moving cursor line. So it will give you like a vertical line, and you can take the line in the area of interest, adjust the depth so that you get like this is the image you are seeing on the lung ultrasound, and you have a pneumothorax here. So you adjust the depth so that you have a relevant depth, and then you put the vertical line adjust in the area of transition, and then it will create certain patterns like here. And I'll not go into detail again to hijack the talk, but different patterns are created with the M mode. Like here on the hard ultrasound or the other focus, you can cut the that particular organ in that particular line, vertical line which you are putting in the screen, and then basically you are putting those dimensions over time. So like here in this LAAO view, you are cutting the aorta and the LA and plotting it over time. So basically over a different phase of the cardiac cycle, and then you can measure the systolic, diastolic diameter, etc. using M mode. In the lung ultrasound, M mode is generally used for creating different artifacts, which our subsequent speakers will be talking. So with that, I'll stop. I think here, just to summary, I think know your machine very well. Go do your basics. Do a 2D scale first to see the lung, and then try to use the M mode to create different artifact. Interrogate all the zones separately. So you have 12 zones or 6 zones, and look at everything, because the lung has a sometimes non-homogeneous disease. So you might have one particular pattern in one area and other pattern is other area, and then that's why you have to do all the zones serially. And then also there are the scores which can be computed, which will be talking. And then if you have a fluid or something, this thing, then you can quantify the fluid. So those are the basics of lung ultrasound. That's it from my side. Thank you.
Thank you, Dr. Kiran. Thank you very much. This is in short time. This is what you all can talk, but still he has given you a kind of very basic understanding of the basic principles. The one question which I feel is relevant, Dr. Shiripad has asked, can we use two transducers simultaneously for 3D localization of lesions?
Oh, wow. That's not right. Good thought.
Good
Uh,
thought, yes.
Good thought, I think. Maybe innovative. Someone can try. So two probes, but how the machine? You need two machines also, because the probe cannot select. We cannot select two probes at a time. Machine allows only select
No, the
one probe.
thing, yeah,
Or
because
you
the
can
thing
have a
is,
3D probe.
whatever. Yes. The thing is, 3D creation, what they do is basically whatever we are doing is 2D. What the machine does, it compiles all the 2D slices and make it the 3D. So it's a derived. It is not actual what the machine is doing. It's a derived image. 3D and 4D are derived images. So that's how they create it. So even we use 3 probes, how many probes we do, machine will not be until if until unless has got a software to do that, will not be able to do. So it is not possible with the normal machines what we have been using it. And Dr. Bhargav was asking regarding, handheld devices like Butterfly.
So in
So,
India, yeah, they are very beautiful. We tried, I think, in Dubai conference, we had those devices. Actually, they are not bad at all. They are actually as good as the normal machines. But in India, because of the PCPNDT Act, if you have it, then you are in you are in the red zone. People will not allow you. You might have trouble. You might get trouble into with your license, because portable machines are not allowed in India. So you can have it, but only use it in your unit without any official this thing, just out of interest or for teaching, but not for doing routine scans or reporting based on that. Maybe that in future it will change. Then maybe you might be able to use it. It's a good machine actually, but currently don't invest, because you will not be able to carry it. You will get into trouble if somebody reports that you are using a portable machine. That's correct, right,
So
Dr.
we
Mohit?
will close this session here. Thank you, Dr. Kiran. And before going to the another session by Dr. Sujit on the our normal, whatever normal signs, things we see in the lung ultrasound, I just have to announcement to make that we will be starting a 3-month certified course on neonatal lung ultrasound, and that will be starting from 9th May. So details are there. So it will be in of 2 versions, online and hybrid. It is for 3 months, and once or twice a week there will be the sessions by the faculty, and then we do have the guest faculty, which is the international faculty, and they will have the lectures. And in hybrid, yeah, if you enroll for hybrid, you will be doing hands-on physical training for 2 days in one of the level 3 NICUs, either in Mumbai, Surat, or Jalandhar. So if anybody is interested, you can save this information for your contact, or you can scan this QR code for the registration. So now we have more than 800 people who are live. So Dr. Sujit, over to you, and you can share your slides for the basic signs what we see in the normal lung ultrasound. Over to you, Dr. Sujit.
It's actually so amazing to me to see so many doctors in such a large number present here on a Sunday morning to attend this CME on lung ultrasound. This shows that the point of care ultrasound is spreading, and we all are getting successful in spreading its awareness among our pediatricians. That's a reason why. That is the reason why insonation has become the 5th pillar in the bedside physical examination after inspection, palpation, percussion, auscultation. Now, this is the 5th pillar. So, as we all know, lung disease is the most common cause of neonatal respiratory distress, which can result in respiratory failure and death in severe cases. Clinical science and chest X-ray we have been doing since so long, but chest X-ray has low sensitivity and specificity. This is just a table to show how effective is lung ultrasound. It was compared with the CT, which we always thought was a gold standard. But now in lung ultrasound, for the different pathological conditions like effusion, consolidation, pneumothorax, almost the sensitivity and specificity is more than 90 to 95%. There are different types of medias in our body, like air, bone, fluid, and soft tissues. So it was always known, and it is known that air is a bad conductor of ultrasound waves. What happens when the ultrasonic waves reach? The air reflects all the waves like a mirror. It doesn't let it pass. And the bone is again not good for ultrasonic waves. It is a good reflector, but it is a bad conductor of the waves. So what the bone does, the density of bone is very high. So it absorbs the sounds and doesn't let it pass through. And fluid and soft tissues, we have always known that it is a good conductor of ultrasonic waves. And that is why till now ultrasound was done for fluid and soft tissues and organs like liver and spleen and heart. So in a standard lung ultrasound or any scan, the beams penetrate the tissue, the fluid, and it gets reflected back to the transducer from the interposing structures. And what the machine does, it interprets the strength of the returning signals and then creates an image on the screen, as Dr. Kiran has explained. So, but in lung ultrasound, when the ultrasonic waves penetrate, they actually cannot penetrate the air, they cannot penetrate the bone, and they get reflected back. And we see some abnormal lines, which are called as artifacts. And then the machine displays a picture of these artifacts. It is not the interpretation of what the organ we are scanning. Like if we're scanning a lung, we are actually not seeing the different lobes and different zones of a lung. It is just the reconstruction of some abnormal lines or artifacts which are interpreted as some and related to some pathological conditions. What we are going through in this lecture today, in short, are the indications, which probe to use, the procedure, how to do lung scan, and what are the modes which we use, what is the sequence of examination, and few normal lung ultrasound signs. So it is lung ultrasound is a need of hour because it is what previously we used to do just in chest X-ray or CT scan, but we know it is a time-consuming procedure. We need transportation, and what we thought that nothing else was better. That is now we have lung ultrasound. The sensitivity and specificity of X-ray is low, and the baby is getting exposed to radiation. The indications for lung ultrasound are whenever your baby has respiratory distress or there is sudden deterioration of respiratory status or maybe some cyanosis, grunting or apneas, or if antenatally you're diagnosed with some lung abnormalities, or you want to see the response to the treatment of antibiotics, or if you're planning for surfactant treatment, in your preterm baby. So pre-surfactant and post-surfactant you can scan, and they even guide you if you need to give another dose of surfactant. You can do lung scoring in RDS, and you can monitor the progress of the respiratory illness. So you can do repeated scans without radiation exposure. But the only limitation is that it is operator dependent. You yourself have to learn the scan. So that is why we are here to train you all and highlight a few things about lung ultrasound. And how is it better than other modalities of scans like X-ray? It's a dynamic, lung ultrasound is a dynamic technique, and we actually can analyze the lung movement in the real time. What's happening there, you can see. And it is very quick to do. Once you're trained, it will hardly take 2 minutes for you to finish the scan. It's a bedside test. There is no radiations. Multiple examinations can be done. The advantage is the neonatal chest thoracic wall is thin, and the width is also small. It is easy to scan the whole area of neonates. The sensitivity, specificity is high. You can also do therapeutic procedures through this. You can decide how much fluid to give to your baby, and lung recruitment assessment has become very useful nowadays. Before extubation of a baby, you can actually see the condition of your lung, if there is any atelectasis, or how is a movement of the diaphragm, and then you can plan for extubation of your babies. This is actually really helpful. And the best advantage is that you yourself are performing this procedure, and you are interpreting it with a clinical course and the condition of the baby. It will be easy for you, because once a radiologist come, he will just give you the interpretation and go. He'll give you the report, but it's you who have to correlate. If so you yourself are doing the lung ultrasound, then you know the clinical course of the baby. The probe which we are using is a linear probe. Dr. Kiran has very well explained why a linear probe is used. It is a high frequency probe. So more than 7.5 hertz is megahertz has to be used, and try to disinfect the probe before doing on every patient to avoid nosocomial infections. You have hockey stick probes which are very high frequency from 15 to 18 megahertz. You will have a better picture for your better resolution for your extreme preterm babies. So when you let's come to the position. It is better to do in whichever position the baby is. You should actually see that the baby is quiet, hemodynamically stable, and ready for the scan. If your baby is in supine, you can do it in supine. If not, you can do it in prone position also, or in a side position. Preferably, we do it in a supine position, but we don't specially turn the baby to supine to do the lung scoring, unless and until you have to do an extensive lung ultrasound. So the position of the probe has to be exactly perpendicular to the chest, no tilting, no sweeping. If you tilt or you sweep, then you might get abnormal artifacts and you might interpret wrongly. And the probe marker should be towards the cranial side, towards the head of the baby. The depth which you have to keep is 3 to 5 centimeters, and you need to adjust the gain appropriately. So this is how you have to keep. This is a hockey stick probe. This is how you keep the probe exactly perpendicular to the chest wall. And this is a probe marker which will be towards the cranial side. Or this is the vertical longitudinal scan, and you can even do horizontal transcostal scan per preferably, most of the time it is easy to go for vertical longitudinal scans. Horizontal scans are done if you want to do it very extensively. You want to see the each intercostal space, especially in pneumonias. So there are two techniques to do this lung ultrasound. They are either 12 region technique or a 6 region technique. So R stands for the right side, and so right region, right side of the chest has 6 regions and left side has 6 regions. Again, the each side is divided into anterior, lateral and posterior, and each of these regions are again divided into upper and lower. So in this way, you have 6 regions on the right side because each region is divided into upper and lower. See, this is how we divide. This is the anterior chest wall. So this is the sternal margin and this is the mammary line. So this way the anterior chest wall is divided into 4 regions. So if we go to the right side, so this is a superior and this is a inferior. So similarly on the left side, superior and inferior, anterior. And this is a lateral. For the lateral area, it is demarcated by the anterior axillary line and the posterior axillary line, and in between is a mammary line. So again, upper and lower. So these are 2 regions on the right and left side. This is the posterior area. This is a spinal line and this is a scapula. At the lower angle of the scapula, you can put a horizontal line. In this way, again, 4 regions on the back. So again, you have a left posterior, superior and inferior, and right posterior, superior and inferior. In this way, you have 6 regions on the right side, which we have named as R1, R2 for anterior, R3, R4 for the lateral, and R5, R6 for the posterior. And similarly, L1 to L6 on the left side, because it is easy for you to repeatedly talk. It is difficult to tell right, posterior, superior. If so, we uniformly know that R5 stands for which region. So it is difficult. It is easy to discuss among ourselves. So there is another technique, which is 6 region technique. In this, you have similar 3 regions on the right side and left side, that is right anterior, lateral and posterior, but you are not dividing them into superior and the inferior region. So you have 3 regions on right, anterior, lateral, posterior, and 3 regions on the left. So these are usually for doing the Brad scoring, we do a 6 region technique. The Brad score is done for RDS. So the modes which we use, commonly we use a B mode, that is a 2D scale or gray scale. But M mode is done to see the moving artifacts. We'll come in detail in next slides. So the anatomical drawing is like this. This is the skin. This is a subcutaneous tissue. This is a pectoralis muscle. These are the ribs. This is 1 rib, 2nd and 3rd rib. In between are the intercostal muscles. This is pleura. This is the parietal pleura, and this is the visceral pleura, and this is a lung. So when we see the same structures in the 2D image, this is how it is visible. These are skin, subcutaneous tissue, pectoralis muscles, and this hypoechogenic, that is the black area, is the rib. And this is the parenchyma. You can compare with the anatomical drawing. So there are few, I'm just trying to highlight the few important normal lung findings. Like we'll go through bat wing sign, pleural line, lung sliding, A line, and seashore sign. Otherwise, we have number of This is another rib. This is the pleura. So it is an imaginary, if you draw an imaginary lines, these are the wings of the bat, and this is the body of the bat. So this is seen as, this is called as bat wing sign, which is seen in a normal lung. The next is the acoustic shadow. As I showed you, this is 1 rib, this is a 2nd rib. There is an area below the rib, which is nothing, where nothing is seen. It is just we can see a black zone, which is called as acoustic shadow. Because the density of the ribs is very high, when the ultrasonic waves come, they hit and they reflect. It is a good reflector, but it is bone is a bad conductor. So nothing passes. And you can just see a black shadow, and this is normal. This is a normal sign of a healthy lung. So this is how a normal lung scan looks. These are 2 ribs. This is the acoustic shadow, which is also called a shadow cone. This is a pleural line, and these are A lines. This is one A line, second A line. Here is a dropout. So we'll go in detail now. This is a pleural line. The skin, subcutaneous tissue, these are ribs. 1 rib, 2 rib, 3 ribs, and 4 ribs. You can see 5 ribs here. In between the ribs is the intercostal space. So this thin, smooth, echogenic, hyperechogenic regular line, which the thickness of this is less than 0.5 mm. This is called as pleural line. This indicates the parietal pleura in all the cases. Why is it formed? Due to echo-reflection. This is an echo-reflection of the pleural lung surface interface. There is a physics involved in this because the pleura and lung interfaces have different acoustic impedance and all. So this is seen as a white hyperechogenic line. And this is a pleural line. And where there is a visceral pleura and the parietal pleura. And in between, there is a little bit of fluid always. So when the parietal and the visceral pleura slide among itself, which is normal, that is called as lung sliding. Visceral and the parietal pleura, they slide over each other. And it appears like a shimmery ant march-like line. It moves. You can see that as if there are ants marching there. That is again indicative of a healthy lung, which is called as lung sliding. So just a video to show you how lung sliding looks. See, this is a pleural. These are the ribs, 1 rib, 2 rib, and 3 ribs. And this shiny hyperechogenic line is a pleural line. Can you appreciate that there's something moving in between? There is some shimmery movement and marching like this is a pleural line, and the pleura is sliding. So lung sliding is present. So let's start with the A lines. A starts, as I told in lung ultrasound, there are different lines going from A to Z. We'll go through the important. A stands for A lines and A stands for air. And we are happy when we have A lines. So what are A lines? The reverberation artifacts which is caused by the pleural line. I'll show you. This is a pleura. These are the A lines. 1 A line, second A line. They are again hyperechogenic, white echogenic lines which are equidistant from the pleura. The distance of first A line from the pleura is same as the distance of the second A line from the first A line. So they are equidistant from each other, and it indicates that there is air. It could be physiological or pathological. So this is how, just an imaginary lung diagram. When the transducer, this is a transducer, and when the ultrasonic waves comes, they pass the skin, soft tissue, and this is a pleura. This dark line, green line is pleura. When the ultrasonic waves comes here, they hit the pleura and there is some reverberation. What reverberation means? This is a movement of the pleura, and it moves in the horizontal way. So there is horizontal reverberation of the pleura, and you can see some horizontal lines which are called as A lines. And these are the ribs, and this is the intercostal space. You have interstitium here. So these are the A lines. This is a pleura, lung sliding present. And these are the 1 A line. This is the another A line. 1 A line, another A line. The next B lines are sometimes normal, but most of the time they are pathological. We'll see when they are normal and when they are pathological. So B stands for B lines. I'm not very happy if I see a lot of B lines in the babies. These are B lines. This is a pleura, and these are the B lines. They are laser-like, echogenic. They are laser-like hyperechoic artifacts which starts from the pleural line, and they go down without fading till the lower zone of your scan. And if they are more, they erase the A lines. How are they formed? They are formed due to reverberation artifacts when there are fluid bubbles in the interlobular and intralobular spaces. So these B lines can be seen normally in the initial 48 to 72 hours after the birth of the baby. But after that, they gradually disappear. So if there are 3 or more B lines between the ribs in one zone, then it is pathological. I'll show you. These are the B lines starting from the pleura and going all the way down. And they move with the respiration. They synchronize with the respiration. They fade the A lines. So this is again a diagram to demonstrate how B lines are formed. These ultrasonic waves come from the transducer, and this is the interstitium. And if there is a lot of fluid here, so when the ultrasonic waves come, they get trapped inside the tetragon bubbles or the interlobular and intralobular septae and all, and they get trapped. And rather than moving in the horizontal way, they start having vertical reverberation and forms the B lines. So these are the vertical artifacts which we see in the lung ultrasound. So see, these they can be just simple B lines. If in whole of the zone you are seeing just 3 B lines, then it is simple B lines. When do you call it a significant? If in between 2 ribs, if there are more than 3 B lines, then they are significant. So if there are more than 3 B lines in between two ribs, that is in one intercostal space, in that entire intercostal space, more than 3 B lines, they are called as confluent B lines. See this figure. They are simple because here and there you can see in the whole zone, here I can see 3 to 4 B lines. So this is simple B lines. If in one intercostal space you are more than 3 B lines, these are called as confluent B lines. Such confluent B lines are seen in more than 3 intercostal spaces like this. Last figure, 1, 2, 3, and almost here 4. In 4 intercostal spaces, you are seeing confluent B lines, then you called as alveolar interstitial syndrome. So this is how alveolar interstitial syndrome looks. There are so many confluent B lines in the scan. This is 1 rib, 2 rib, 3 rib, 4, 5. So almost 4 to 5 intercostal spaces have confluent B lines. So when there are so many confluent B lines that the acoustic shadow, which I told there is a black zone due to the rib, if the black zone, the acoustic shadow also disappears, then it is called as compact B lines. And when do you call them as white lung? It is seen when each of the scanning zone on the both sides of the lung has this compact B lines, then you call them as white lung. So this is one video where this is skin, subcutaneous tissue. These are the ribs. This is a shiny, shimmery pleural line, hyperechogenic line, regular, smooth, and it is also moving. There is movement, shimmery ant-like movement. This is called as lung sliding. This is also present, but I can hardly see few A lines. So because we have lot of confluent B lines here, which are starting from the pleural line and they are going down up to the screen without fading, and they are moving with the respiration. So I can see in one intercostal space, in the second intercostal space, and most probably it is there in third also. So this we can call it as alveolar interstitial syndrome. So there's another terminology, comet tails. They are similar to B lines, but they start from the pleural line, but they fade away. They fade away. They do not reach to the lower line of the scan zone. And these look like B lines, but they are not. They are also reverberation artifacts, but they weaken as they go down. So these are not of much significance. Then next is the M mode. As Dr. Kiran showed you, why M mode is done to, it is done to see the moving structures. So in lung ultrasound, I'll show you, this is an intercostal space, right? Like here. This is one intercostal space. When you're doing the scan, put a M mode here. You put a M mode here and then you get a image. Like this. You have put an M mode and you can see this picture here. This is called as seashore sign. In a normal lung, when you put a M mode, you can see an echogenic pleural line which is dividing the image into two parts. One is the upper part, another is the lower part. The horizontal line, it divides the into upper and the lower part. The horizontal linear pattern of the tissues, that is the skin, soft tissue, muscles, which are superficial to the pleural line, looks like a C. They are the motionless part. And the area below that, below the pleural line, looks like a grainy or sandy appearance of the structures which are present deeper to the pleural line, that is the lung. It looks like a grainy or sandy appearance, that is the shore. This indicates that there is normal to and fro motion of the lung. So lower area is the, you can see in this picture, this echogenic bright white line is the pleura. The motionless, the soft tissue areas above, that include skin, subcutaneous tissue, and the muscles and all, are seen as a horizontal lines. This is the C. And this is the pleural line. The area below that, I hope you all can appreciate, this looks like a sandy beach. So this is called as a sandy beach appearance or sea shore appearance. So this is seen in a normal healthy lung. Line, which is the white line, and the areas above the white line includes the superficial tissues, which looks like a C, and the area below that looks like a grainy area, which is the lung. So this is called a seashore sign, which is a normal sign in a healthy lung in M mode. So I just wanted to convey that you have to correlate your ultrasound findings and artifacts with your clinical findings, and then you should make a decision what the diagnosis is and how the treatment has to be done. So the learning is the beginning of wealth, beginning of health, and the beginning of spirituality. Searching and learning is when a miracle process all begins. So I'm hoping that the miraculous process of learning lung ultrasound begins for all of you today. Thank you.
Thank you, Dr. Sujit. I think so. We will take the questions in the end.
Yeah,
just
sure.
very quick. They were asking regarding the recording. Yes, recording will be shared with everyone who has already registered and whose name is there in our list. So we will share the recording, but that will take around a week or so. So within next week, we will share the recording. And there were things people were asking how to disinfect the probe. So any one of you can answer. Dr. Sujit, you can answer this, please. How to disinfect the probes? This is 3 or 4 common questions people have been asking.
To disinfect the probe, you can just use a normal saline and clean the tip, and ideally you have to clean the whole probe and the wire also, because sometimes there is dirt all over the wire also. So you have to take a sterile gauze and then clean, and the jelly which you use, we get separate jellies which are sterile. It is better to use them. Preferably do not use the sterilium or alcohol for the transducer.
Thank you very much. And this is for sport. If you can please post in the questions from the participants group in this chat box. So we will take it after the sessions in Q&A session. So before moving ahead, again, just one announcement. Those who have joined later. So the announcement is we are going to start with on 9th May, we are going to start a 3-month certified course in lung ultrasound. That will be of 2 versions, online and hybrid. 3 months course certified. And if you opt for hybrid, along with the online, all the sessions, you will be having 2 days of hands-on in-house training in level 3 NICU at Mumbai, Surat or Jalandhar in rotation. Those who are interested, this is the contact details, phone numbers, WhatsApp, email, or you can scan this QR code and register for the course. So what I will do is, so difference between the hockey stick and the linear probe. Okay. So what I will do now, I will be doing this live demo session video for you people for this normal lung ultrasound science, what Dr. Sujit has just discussed. So in that, I will also show you the hockey stick probe. The hockey stick probe is a linear probe that has been used for the newborn, specially designed for the newborn. So the footprint size is very small. And that is what I will just share with you and show you also. Everyone is able to see my screen? Dr. Kiran or anybody can answer, okay?
Yeah, we can see the
Yeah, we
screen.
can see.
You have to play the video, yeah.
So this is what I'm showing. This is the hockey stick probe that I'm showing you. So this is the linear array probe, and the free end is the probe marker. So the only difference is it is of high frequency. The frequency of this probe is 12 to 15 hertz, and it is a linear, and the size of the footprint is small as compared to the linear probe, what we use in adult and the pediatric age group. So this is your hockey stick probe. So I'm just showing you the free end, that is the marker. So this is regarding the probe, and this is the screen. Like in my machine, this is your CX50 Philips. I have a preset. So in the preset, already the lung ultrasound is being set. So as soon as you will do, it will come and see this is 15 hertz. Here, the probe marker. This is a probe orientation marker on the screen. In the free end of the probe is a probe marker. So your probe orientation marker will always be on the right side of the machine. If you're doing radiology, if in cardiology, this probe orientation marker will be on the left side of the screen. So my marker is here and this corresponds to this. So this is your probe orientation marker. Okay, so it has already been set in lung ultrasound. In the depth, you can see it is around 3 centimeters. Normally, we keep the depth for the lung ultrasounds in between 2.5 to 3 centimeters. So this is the baby. You have to keep the baby's spine, as Dr. Sujit told you, and this is how we divide the chest, like here. This is a sternum on both the sides. So this is your sternum, right and left. This is your anterior axillary line. Then you have a posterior axillary line, anterior axillary line, posterior axillary line, right and left part of sternum. And when you want to do the posterior lobes, always try to put the baby in the lateral position, and then you will have a scapular edge. So that scapular line will be there. So the area between the posterior axillary line, anterior axillary line is the lateral lobe, lateral area, anterior axillary line, and in the sternal line is the anterior zone. And then from the posterior axillary line to the scapular line is the posterior zone. So we have 6 region approach. Similarly, that was on the right. This is on the left. Anterior axillary line, posterior axillary line, and then you turn the baby lateral to the right side, and then you have the scapular line here. So that is the posterior zone, lateral zone, and then you have the interior zone. So 3 regions on the right, 3 on the left. So that is 6 region approach, and then horizontal line. If you draw from the nipple horizontally till this scapular tip, you have 6 regions on the right and left. Like I am showing you interior up, right and left, upper and lower. And then similarly, you will have upper and lower lateral, and then upper and lower. This is upper and lower lateral, and then similarly you will have upper and lower on the posterior zone. So that is a 12 region approach. 6 region and 12 region. This is how you divide the zones on the baby. Okay, and then in the end we use one transdiaphragmatic. We put the probe on that, both right and left. Right is more important because the liver is there. So from this tip where the posterior axillary line is there, so at that point half probe should be above in the lungs and half should be below. And this is the technique by which I am putting the probe orientation marker is facing towards the head. it is perpendicular to the ribs. So there are two ways you can do it, either putting the probe perpendicular to the ribs or in line parallel to the ribs. Normally in practical, we commonly use this technique of putting the probe, which is the foot of the probe is perpendicular to the ribs. So this I'm putting in the left upper, then lower, right upper anterior. So that was left upper anterior, left lower anterior, right upper anterior, right lower anterior. Similarly, you can put it in the lateral zones and then in the posterior zones. So this is lateral upper, left lateral upper, left lateral lower. And then we're putting the baby in the lateral position. So this is left posterior lower and upper. In all the things you have seen, my probe orientation marker was facing towards the head of the baby. This baby's lungs are normal. This baby was operated for some intestinal, I think so. There was a jejunal gangrene. So this is how we put, and you see this. I told you regarding the depth. So depth we have kept it as 3 centimeters. So this is in the penetration mode, means it will be cover more depth because of term babies. If it is preterm baby, then I will put it in the resolution mode in which the frequency will be higher. So what are things I'm showing you? I'm showing you this is the skin, subcutaneous tissue. These are the black ones are the ribs, and this is the intercostal muscles. And this white hyperechoic shadow which you are seeing is the pleural line. So this is the pleural line, and this pleural line which is moving is your lung sliding. So this is lung sliding. Pleural line is moving. This is lung sliding, and this horizontal lines what you are seeing are the A lines. And the vertical lines, hyperechoic lines, which are starting the pleural line, they are moving along with the pleural line, are B lines. And this is the M mode button in which we can use the, do the M mode, and we will do the, what you call as the seashore sign in this thing. So that if your lung sliding is present, only then you will see the seashore sign, otherwise you will see a stratosphere sign. So this is your M mode. I'm doing, it's going through the pleural line. So this is seashore sign. So this is water. This is the subcutaneous tissue. One is the water. Hyperechoic border is the pleural line, and this is lung tissue. This looks like a beach. So sandy beach sign, or what we call as the seashore sign. These vertical laser-like things, what you are seeing, the ones that start from the pleural line, or which are moving and goes till the end of this segment. The ones that start from the pleural line goes till the end of the segment, they are the B lines, hyperechoic. The ones like these you are seeing in between, which start and then they fade away in between. So those are the comet-tail artifacts. The ones that are laser-like going from the pleural line and going till the end of this section. So those are the B lines. The ones that disappear in between. So those are the comet-tail artifacts. So you can see comet-tail artifacts and the B lines. And the horizontal hyperechoic lines are the A lines. In between the two ribs, what we have one segment, we call it one segment. Then we look for B lines in this one segment, and Dr. Anu will discuss regarding that. And then we classify it as whether they are B lines, confluent B lines, and then AI, like this example I have just shown you in another baby. So here you see these are two ribs, one segment, then here is one segment. It is all white. So they are hyperdense. They're all B lines, confluent B lines here, and here. So in 3 segments, if you have confluent B lines, so that is known as AIS, alveolar interstitial syndrome. So I just show, and you cannot see A lines in this. So I just showed you to compare this with the previous ones. The last ones which I show you, in which you were seeing A lines, some comet-tail artifacts, and B lines. And the other one, which I just shown you, was your confluent B lines in all the sections. So it was AIS. So these are cometal artifacts, B lines, and these are the A lines you can see in this. Okay, so different sections of the lungs we are doing. So very nicely you can see this B line. So now that was a term baby. So this is a preterm baby. So I just want to show you another lung ultrasound, that how, the picture of the preterm baby lung ultrasound is different from the term which was on room air and very stable. And this baby is preterm baby and is on NIV, non-invasive ventilation, with the pressures of 16 to 18 of PIP. Okay. So in this, you will see more B lines like this, you see. And then we do the scoring. Regarding the scoring, Dr. Anup will be telling you, as he will be discussing the lung pathologies. But here you see more number of B lines, and it differ from various zones. So this is how you see now. I am showing you, this is AIS, alveolar interstitial syndrome. So you have confluent B lines in this baby. So I am just telling you regarding the score. Like in the score, if you see A lines, the score is 0. This in detail, Dr. Anup will be discussing. So I don't want to discuss all this in here. So my main objective was to show you how these normal things will look like ribs, skin, subcostal, intercostal muscles, pleural line, moving pleural line, what we call as the lung sliding. And then you have A lines, horizontal hyperechoic lines, vertical lines are the B lines, and then how you have the B lines and confluent B lines you see. And when we put M mode, you see the sandy beach sign, or what we call as the seashore sign. So I just, for your reference, I did the ultrasound in the preterm also, just to show you how the RDS lung, if you have RDS or a premature lung, how it looks like and how it differs from the term lung. Okay, and this is a minute details of this is thickening of the pleura and subpleural consolidation, the scoring changes. So that that Dr. Anup will discuss. And this is a baby with a pneumothorax. Already the chest tube is in. I did that just to see whether there was a pneumothorax so that I can show you. But actually the whole of the air got drained, so it was not useful for showing you. So this is the last thing which I want to show. I have kept this probe in the transdiaphragmatic area. So here you can see towards the head end, this is the lungs, ribs, pleural line, you can see B lines, and here you can see the liver. So you see liver in one half and the lungs in the other half. So this is a transdiaphragmatic. This is important. This is very important to look for any lower lobe consolidations, or you have a pleural effusions can be very well made and differentiated in this particular view. So this, we should end this thing. So we should end our all lung ultrasound with the transdiaphragmatic view in either in the right or left. Now this is a question for you people. Just write down in the chat box in this video. Just write down on which mode of ventilation this baby is. What is the mode of ventilation in this baby? I'll just show you again. Yeah, the mode of ventilation in this. Write down, and this is for your brownie part. This is another lung pathology. If you can write down this, that what is the pathology, that is the brownie points for all of you. Again, the mode of ventilation in this baby. What is the mode of ventilation here? So with this, I will stop. So for the sports staff, if you can, whatever they write in the chat box for the answers of that question, please put it into your, please put it in your copy. Yes, most of the people have answered it. HFOV, very nice. So the baby was on high frequency ventilation. It's for now. The next talk will be on lung pathologies. I just showed you, but in detail, quickly, Dr. Anup will be discussing with you. Before going there, I just want to just share that announcement again. Those who have just joined, we are going to start 3 months certified lung ultrasound course from 9th May. These are the details, 2 versions, online and hybrid. 3 months course will be there. International, national faculties will be involved in that. And it will be in the hybrid one, you will have 2 days of hands-on sessions, learning session in-house in level 3 NICU. And those who are interested can save this contact details. You can scan this QR code for registration, or you can send us the email or WhatsApp us. Thank you very much. So now we have Dr. Anup with us. So he will be.
Should I share my screen, sir?
Yes, please. So he will be doing. So somebody has asked Dr. Anup that why it was HFOV, that video.
I did not see the video. It must be like
Okay, sorry. Yeah. So it was all wriggling. You were
okay.
seeing the wriggling. There was a wriggling, and even in the previous babies, the movement of your pleural lines was different and was very slow. But in the video, in the the pleural line was wriggling. So
Okay,
that's why
great.
baby was HFN movie. So great. So we have now an great expert of of lung ultrasound. He has been one of the um, pioneers in writing many of the articles and this thing. So on lung ultrasound. So it's great to have Dr. Anup with us. So over to you, Dr. Anup.
Yeah. So thank you, Mohit sir and Dr. Kiran, for giving me this opportunity. Actually, lung ultrasound is a topic which is very close to my heart. And I'm doing a small part here, which is lung ultrasound, various disorders. And I had intentionally made the presentation short because we didn't intend to dive too much into the details. Lung scoring, as Dr. Mohit was saying, what I have done, we have taken a case also. So in the case, I will discuss the lung scoring so that we don't have overlaps in the case and the presentation. So when we talk about various disorders in lung ultrasound, we have to understand that one of the principles of lung ultrasound that it is based on simplicity. So whatever disorder it is, everything has got just 4 lung patterns. So the normal patterns are only 4. You saw a normal lung pattern, which is classically the bat sign in the 2D mode and the seashore sign. Some A lines could be present or they will be absent. 1 or 2 B lines is fine. So that's a normal lung. Abnormal lung has got 4 patterns. So one is interstitial syndrome, one is pneumothorax, that means there is air inside the pleural cavity. Third is pleural effusion, and fourth is consolidation. So there are only 4 abnormal lung patterns. It's very simple. All the disorders which are there in the lung, whether you call it hyaline membrane disease or meconium aspiration syndrome or bronchopulmonary dysplasia or transient tachypnea of newborn, all these have been described by neonatologists based on these patterns. So the basic principle lies here, these 4 patterns, and rest all disorders in newborn are derived from these patterns or by intermingling of these patterns. So we need to understand these 4 patterns first. The first pattern, which we are going to talk about, is the interstitial syndrome. And Dr. Mohit gave you some idea about the interstitial syndrome already. So first of all, you have to understand that what is a B line, which Dr. Sujit has described very nicely. So whenever you are seeing an ultrasound and to say whether you're in the lung or not, you must be seeing the ribs. Okay. So you see the ribs are here and they cast a acoustic shadow behind because the ultrasound beam are not able to penetrate through the ribs. And just below the rib, you see an echogenic line, which is the pleural line. So this is your starting point of lung ultrasound. Without this, you should not be commenting on lung ultrasound. Then if you look at this picture, you will see there are multiple echogenic lines which are traveling. Now, whether to say these are B lines or not, there are certain criteria. There are 7 criteria which Dr. Mohit was trying to emphasize during her presentation. One, they arise exactly from the pleural line. They are comet tail-like. They are echogenic. They travel up to the end of the stream. They may spread, but they do not fade. They will erase the A line, and most of them, 97% of them, will move along with the fluid line. So that's what we call as criteria to level any comet tail artifact as a B line. If this criteria is not fulfilled, we don't call a line as a B line. So that's the first concept about the B line. Now, you see what is happening in this screen. There are more than three B lines in between two ribs. Okay. So the concept of interstitial syndrome, it came from adults, and it was defined as when there are presence of three or more V lines in between two ribs. This were called lung rockets. Lung rockets because they looked as if a rocket is taking off from the earth. So when there are three or more V lines in between two ribs in the anterior lung fields in a dyspneic patient. So there are three criteria now: three or more V lines in between two ribs in a dyspneic patient in the anterior chest wall. So there are three criteria. Plus, you add on the seven criteria of B lines, which I have already described to you. So 10 criteria. If those 10 criteria were fulfilled, then the adults will said to have interstitial syndrome. So three or more B lines in the anterior chest wall in a dyspneic patient, these three criteria plus seven criteria of B line. So here you see there are presence of lung rockets in between the two ribs. So this is again a picture of interstitial syndrome. Here there is thickening in between. This is called a squirrel tail variant. Okay, and this is again interstitial syndrome. So what happens? Why these kind of patterns are formed? You need to understand that these B lines are aerohydro artifacts, air and water together. Okay, so entire lung ultrasound is based on the concept of interaction of air and water. Okay, so lung is 99% air and just 1% water is there in between the pleural space. So whenever there is decrease in the aeration of the lung or increase in the water content in the lung, then you will see appearance of the B lines. Okay. So gradually as the aeration decreases and the water content increases, so there's alteration in the air and fluid ratio, you will see more and more B lines will start to appear. So this is here is just a single B line. Here there are two B lines. Here the appearance of lung rockets. So lung rockets, that is three or more B lines in between two ribs, especially in the anterior chest wall, are not normal. So this is a pathological variant. And as gradually in any disorder, when the aeration will decrease and the fluid will increase, these B lines begin to increase further. So more and more B lines leads to a pattern where you will see that the entire space below the pleura. So this space below the pleura is called the Merlin space. So if you see in the Merlin space, there are multiple B lines and there are barely some spared spaces. Spared space means these black spaces. So this is again called as ground glass rockets. That means further the aeration in the lung is decreasing. And as the aeration decreases and fluid increases, you may find that the B lines are so many in number that you have no spared spaces in between. There's nothing which is echogenic. Everything appears like a white out area. And this is the most severe variant called the Birulu variant. So this is here where there are no spared spaces and the B lines are multiple. But still you can see the rib shadows, you can see the pleural line, that means you're in the lung. So this is the progression, what happens with decrease in the aeration and increase in the fluid in the interlobar spaces. This tells you about the progression of a disorder. Okay? And when you have disorder from here onwards, that is three or more B lines in the anterior field in a dyspneic patient, then this is called interstitial syndrome. These are lung rockets. These are called ground glass rockets. These are Virudu variant. You can leave the details, but from here to here, all these are pictures of interstitial pattern of the lung. Okay. Now, what is the relevance of this lung rockets or interstitial pattern? Is this a disease or it's a pattern? It's a pattern which is found in various disorders. So you can find interstitial disorder, interstitial syndrome in ARDS or in hyaline membrane disease in newborn, where there will be decrease in the aeration and increased fluid in the interstitium. So it can present with a similar kind of pattern. So there's a commonest disorder where we see interstitial syndrome or interstitial pattern in newborn lung. Then it helps to rule out pneumothorax. Why? Because pneumothorax is all fluid, right? So all water, okay? And there should be no B lines, okay? So even if you find a single B line in that particular place where you are trying to see for a pneumothorax, and if a single B line is present, it rules out pneumothorax, okay? So when the presence of a single B line in a field helps you to rule out a pneumothorax. Then interstitial syndrome may also be found in conditions like hemodynamic pulmonary edema. So, for example, there is a scenario of congestive cardiac failure or the scenario of fluid overload. In those scenarios also, you will find the same pattern, the interstitial pattern may be found. It might be found in pulmonary edema, which is because of inflammation or permeability induced. So there could be pulmonary edema because of pneumonia, severe pneumonia also, even that can give rise to interstitial pattern. But there are subtle differences. I mean, there are some profiles, which is again for the advanced learner, which we can skip. So other relevance of interstitial syndrome is in controlling fluid therapy. When you're giving fluid boluses in shock, you know where to stop, where not to stop. Lung expansion, vening presence, hyponatremia. These are all again for the advanced learner. We can skip this. Okay. Now, the second pattern which you need to understand apart from the interstitial pattern is the pattern of consolidation. So what do you find in lung ultrasound in consolidation? So you will see the ribs and the shadow of the ribs. Okay. And what you see in consolidation, what happens basically, one is that you may not see a regular nice fluid line. We'll talk about it again. And instead, you see in the lung parenchyma, there could be multiple echogenic areas, okay, as if these are called the shred signs. So, multiple echogenic areas in the lung parenchyma in the Merlin space is called the shred sign. And as if some rat has come and it has eaten this area and shreds of bread are left behind. That is how Lincolnstein thought about the name, the nomenclature shred sign. And shred sign is one of the signatures of a consolidation. Okay? Remember, this pattern of consolidation could be found even in Halley's membrane disease if it is severe enough. It could be found in meconium aspiration syndrome. It could be found in bronchopulmonary dysplasia. It could be found in congenital pneumonia. Okay, so the pattern of consolidation could be found in all of these conditions. Then you have echogenic structures like this in the Merlin space. It is called the shred sign. It is one of the signs of consolidation. Similarly, here, if you see, this is another of one of our patients. So if you see here, these are the ribs. Here's some black shadows of the ribs. And you can't see the pleural line very clearly. So pleural line is either broken, it's irregular, or it's thickened. So when the pleural line is broken in a case of consolidation, we call it the fructal sign. Fructal sign, it comes from fracture. Fracture means breakage. So the pleural line could be broken. This could be another sign of consolidation. Okay. So here you see the fructal sign, and here you can see the shreds lying here. So both these signs are found in consolidation. Now let me show you what can happen in consolidation also is, so these are hyperechoic shadows in consolidation. This is the lung line, the visceral pleura, which is being attached along with the lung, and the parietal pleura is somewhere above. And what is happening here? Here there is accumulation of fluid. So in consolidation, you must have learned that sometimes there is inflammatory fluid also along with. There is symptomatic consolidation, and you can find sometimes fluid effusion along with consolidation. And to see this, the best place is what we call the Plapp's point. The Plapp's point basically is the posterior most area that Dr. Mohit was discussing. So it's a pleural alveolo pleural syndrome point. So it's a posterior lateral alveolar pleural syndrome point lying in the posterior walls. And you can see the fluid also along with the consolidation, the shred sign. Now let me show you a video which has all the signs together. So this is a term neonate day 5 and had history of meconium aspiration syndrome, was on ventilator, referred to us on day 5, and this is the ultrasound at admission. So you see here what is happening. So you see here the pleural line here. Here the pleural line is irregular. Okay. And you see here there are shreds lying all through. So the irregular echogenic content which are lying in the Merlin space. You see some bit of V lines here forming an interstitial pattern as well. And you see this area, this hypoechoic area, it contains fluid as well. So here you have all in one place. You have the the shred sign here in the Merlin space, the echogenic contents here. You have fluid here lying along with the consolidation. You have the fructal sign, the irregular pleural line here. And this all is also known as C profile for consolidation. So this particular video shows all the patterns of consolidation. Along with that, there is one more sign which is found in consolidation that is called tissue-like sign. Okay. And there what happens, the entire lung starts to look like a tissue. So that is found only if there is lobar consolidation, huge consolidation. Then you can find a tissue-like sign in that where the lung looks like a river. Okay. So this is the second pattern of consolidation. Now, if you come back to the pathology of in neonates, since we all are pediatricians and neonatologists, so you see what is happening in hyaline membrane disease. What do you get? So there are ribs, okay, and you're getting the acoustic shadow of the ribs as you keep your probe longitudinally, and you see the pleural line here, pleural line just below the ribs. And you look at the Merlin space here. This is called the Merlin space. The entire Merlin space seems to have formed a whiteout pattern, which is because of multiple V lines joining together. So it is nothing but a interstitial pattern, which is again seen in hyaline membrane disease. Now, as the hyaline membrane disease becomes more severe and the aeration decreases further, then you start to see changes of consolidation. In milder forms, you will see the consolidation just below the pleura. So these are called subpleural consolidation because they are just below the pleura. And when the consolidation are extensive, like this one here, then you find areas of shred being formed. So look at this picture, lung ultrasound of a baby who has hyaline membrane disease. It is a combination of interstitial syndrome and it has a combination of consolidation. So basically, two patterns are being present here of the abnormal lung, interstitial syndrome and consolidation. So here the consolidation is subpleural and here the consolidation is florid, and this is the corresponding X-ray of the child. Again, this is again HMD, severe HMD. You see the X-ray, it's very bad. And here again, you see that there is shred sign, multiple shreds in the Merlin space, some fluid as well, and also the pleura is irregular. Okay, so that's what you're going to see in hyaline membrane disease. And we'll talk about the scoring system when we discuss a case of HMD. Now, what happens in transient tachypnea of newborn baby? So TTNB. So in TTNB, what is happening? There is increased fluid in the interstitium. That's what we know. There's decrease in the clearance of fluid from the lungs. So in TTNB, the classical finding which has been described is this presence of B lines in the lower lung fields. So if you keep your probe in the lung longitudinally, anteriorly, then what will happen? The lower lung fields, they will have increased fluids and they will show more of confluent B lines. The upper lung fields are clear. Okay, so this is one rib, this is another rib, this is one space, this is a pleural line, nice, sharp, echogenic pleural line. These are A lines. These are another A line here. They are equidistant from each other. Okay, so this is one space which is clear and there is barely any B line here. When I come one space down, again, I see the pleural line here, and I can't see the A lines here because they have been erased by the B lines, and multiple B lines have joined together to form a more like confluent kind of pattern. So these pattern that of confluent B lines in the lower lung fields and clearer kind of lung in the upper lung fields, these might be present bilaterally in both the sides. And therefore, one of the authors named Copetti, he named it as the double lung point. So double lung point was something which was said to be very specific and sensitive about TTNB. Later, people found that it's also found in other disorders. So this is a finding in TTNB, and you see it is basically nothing formation of interstitial pattern in the lower lung field and clear lung in the upper lung field. That's what you'll find in transient tachypnea of newborn. Again, the same thing, you see the lower lung fields are having a kind of confluent B lines and upper ones are clear. Now, talking about pneumothorax. So one of the beauty of lung ultrasound is that it can help you to rule out pneumothorax in matter of seconds. So that's a beautiful thing that lung ultrasound can provide you in a crashing neonate. So the normal lung features had been described by Dr. Surjit, where you see the ribs and you see the acoustic shadow of the ribs and you see a sharp echogenic pleural line. This is called the bad sign. And when you put in M mode, then what happens? The area above the pleural line, this will show you the straight pattern, okay? And the area below shows you a granular pattern. And this, in the standard nomenclature, we call it as a seashore sign, okay? And this granular pattern stops exactly at the pleural line. So if your machine which gives you picture side by side like this, then that's a good machine because you know exactly where the granular pattern has stopped. So this is the seashore sign of a normal lung, and this is what a bad sign looks like. Now, what happens when you see this in real time, this is what you will see. This is a rib, you see, nice rib, here nice rib. These are the acoustic shadow of the ribs. These are the pleural lines, and you see the pleural line, the visceral and the parietal pleura, they glide against each other. Okay, and when they glide against each other, they produce certain artifacts in the Merlin space. And you see the Merlin space, there are so many artifacts being produced. These are compared to as twinkling of stars, or crawling of insects, shimmering of stars. So you see some disturbances here. These disturbances are transmitted because of the sliding of the visceral and the parietal pleura, and this is called lung sliding. Now, when you put an M mode here, line here in between the ribs, you get the seashore sign. So you see the space above the pleural line, you see all straight lines. So this space is called the key space. It has got all pleural lines, and below you have the granular pattern. So straight pattern and the granular pattern. This is more like waves of a sea. This is more like the shore, and therefore it is called the seashore sign. The standard nomenclature again is seashore sign, and you see the M mode being applied in between the two ribs. Now, if I compare this image, you see here the pleural line, and you see here what are the things you can notice here. It's interesting. You see there is no lung siding. Okay, the visceral and the parietal pleura, they are not rubbing against each other, and the Merlin space is virtually silent. Nothing in the Merlin space you're getting. Okay, so no lung sliding is present. That's number one thing which I can observe here. Number two, what I observe here, I see multiple A lines. See multiple A lines. Okay, so A line stands for air. Air can be quasi-pure, that is some air, some fluid present in the lung, or it could be pure, that means only air. So pneumothorax is a condition where there's only air in the lung. So there's you see a lot of sharp A lines being seen here. Okay. And in between the A lines also you see certain small lines, horizontal lines, which are the sub A lines or the pi lines. So one I observe, there's no disturbance in the Merlin space, that is the lung sliding is absent. Second, I observe there are multiple A lines. There are multiple A lines, very sharp A lines I am seeing. And third thing, what I observe when I'm searching for a pneumothorax in this area is there is not even a single B line here. Remember, I told you that B line are hydroaeric artifacts. That means there is no fluid, so it could be only air. A presence of single B line in that particular zone we are searching for a pneumothorax rules out a pneumothorax. One B line found, no pneumothorax. So there are absence of B line. So right now I have got three signs which point towards pneumothorax: absence of lung sliding, multiple A lines which are prominent, and absence of B lines. Further, what I'm going to do, I put an M mode here. Okay, so this is an M mode of a patient who had pneumothorax. And when I put the M mode, I see the straight pattern. I see everything is straight. I cannot see the classical seashore sign, right? So it's a straight pattern in the same patient I'm putting. And this is called the stratosphere sign. Okay, stratosphere sign. This is the fourth sign of a pneumothorax. And the stratosphere sign tells you that the lung sliding is absent. So it is a surrogate marker of absence lung sliding. In the same way, the seashore sign is a surrogate marker of lung sliding present in the M mode. So in the M mode, there is no lung sliding and you're getting stratosphere sign. So we have four signs now which point towards a pneumothorax. The fifth and the definitive sign for a pneumothorax is called the lung point. Okay, lung point is the pathognomic sign for pneumothorax. No other disorder in the human body can produce the lung point if you're in the lung, right? So what happens basically when there's a pneumothorax, air rises up. Okay, so you look for pneumothorax in the anterior chest wall. And so when you move your probe from lateral or from posterior to anterior, the posterior part where there is no pneumothorax will have a normal lung. So it will have a seashore sign in the M mode. And as you move your probe anteriorly, upper part, you will finally reach a point where there is a pneumothorax, where you find the stratosphere sign. So the junction between the normal lung and the abnormal lung is the lung point. Okay. And if you find a lung point, it is definitive of a pneumothorax. So you look for pneumothorax in a sequential way. And the five signs which you see is no lung sliding in the 2D mode. There's absence of B lines. There's plenty of A lines. The stratosphere sign, was everything was going like straight kind of pattern, and the lung point. So this is the first lung point, which like when I got trained from Paris 2017, then the patient had a pneumothorax, and I could get this lung point in the patient. This is what you're looking for, and this is definitive for a pneumothorax. Okay, so these are the five classical signs of pneumothorax. All five must be present. Do not put the needle just based on stratosphere sign, because stratosphere sign or absent lung sliding can be present in various other conditions other than pneumothorax. There's one caution which I'll give you. This is the patient who had a huge pneumothorax, and we're trying to do the scan on that patient. The last and the final pattern is called the pattern of pleural effusion. So in pleural effusion, what is happening is there is fluid in the pleural space. So the visceral pleura and the parietal pleura, so they are split by fluid in between. Okay? The visceral pleura is attached with the lung, and the parietal pleura gets separated. Okay? So if these particular area you can bound, so this is one boundary, this is the boundary, and the acoustic shadow of the ribs above and below. So one rib is here. So one boundary we can imagine comes like this. One rib is here. One boundary comes like this. So these forms a quadrangular area, which is called the quad sign. And quad sign tells you that there is fluid in between the two pleura in the pleural cavity. And when you put an M mode at this particular place, what you get is in the fluid. So in the fluid, what happens? The lung and the visceral pleura, they move with respiration. Okay, they move with respiration in the M mode. This is called sinusoid sign, which is again found in the M mode in pleural effusion. So this is again a lung scan of one of the patients which we had, and the patient had high drops. And you see here, this is the space above is the key space. There's some fluid because the parietal and the visceral pleura are split. Above is the parietal pleura somewhere, and the visceral pleura is attached to the lung. And as the patient breathes, the lung moves freely in the fluid, and this gives rise to the sinusoid sign found in pleural effusion. Okay. So, simply speaking, if you talk about the patterns and signs of lung ultrasound, there are just 12 signs, and rest all are different kind of signs, nomenclature, signatures, which are given by various authors who wrote articles on lung ultrasound. Okay, so these 10 signs are one which all of you should be familiar and very clear of their criterion. So the bat sign, which is seen in normal lung, the lung sliding, which you can see in the 2D as some disturbance in the Merlin space, the A lines, which signify air, quasi-pure or pure. Quasi-pure means air in normal lung, and multiple A lines, pure means air in pneumothorax. So A line, which are horizontal line because of duplication artifact of the pleura. Quad and the sinusoid sign, which is found in pleural effusion. I just showed you how they look like. The shred sign, which is classically found in consolidation, and the tissue-like sign when the consolidation becomes massive, when it is an entire lobar consolidation, the lung looks like a tissue, like a liver. We talked about the lung rockets, which is found in the interstitial syndrome because of decreased aeration or increased fluid. And the lung rockets could be found in HMD, it could be found in pulmonary edema, and so on. And we talked about the stratosphere sign and the lung point. The lung point being definitive for a pneumothorax, and the stratosphere sign, which signifies that the lung sliding is absent. So these are the only 10 signs which you should remember when you talk about lung ultrasound. Two more additional signs, lung pulse and air bronchogram, I have not talked about intentionally, not to make the subject very complex. So what we talked about is interstitial syndrome, the pattern which denotes there is decrease in the aeration, increase in the fluid. This may be found, you saw in HMD, this may be found in pulmonary edema, this could be found in pneumonia. Even in consolidation, sometimes you can see some pattern of interstitial syndrome. In consolidation, classically, we talked about the shred sign, where there are shreds in the Merlin space, the fructal sign, which is the breakage of the pleura, or the pleural line could become thickened, or tissue-like sign, and sometimes we find the C profile and fluid also along with. In pleural effusion, we talked about the quad sign and the sinusoid sign. Pneumothorax, I told you, conventionally look for the five things, that is absence of lung sliding in 2D mode, plenty of A lines, absence of B lines, stratosphere sign, and finally the lung point. And we saw some videos of abnormal neonatal lung. You can go through this article. This was published 3 years back. It's written with a lot of love and zeal. You can just read about these signs in this particular article. and that's Daniel Lincolnstein, and that's the hospital where I was trained in 2017, almost 8 years back. And as Dr. Kiran More told you, he's the father of lung ultrasound and is the right person if you want to know the concepts of lung ultrasound from. And thank you, Dr. Mohit, so much for giving me the opportunity.
Thank you, Dr. Anup. It was great. Like, it is very difficult to concise almost 3 or 4 sessions into one very small session, and that you have summarized very nicely, and we are really thankful to you. There are few questions, not few, many
Yes,
questions.
sir.
Well, I think so.
Okay,
We will
sir.
just, as it is in the quick session, we will just finish it off. There is a question by Dr. Rajiv: how to differentiate lung ultrasound findings between empyema and lung abscess?
So both are different conditions, and when we talk you about the lung ultrasound signs, so it is the character of the fluid which can tell you. So if you are thinking about pleural effusion or empyema is nothing, the pleural fluid is plus. Okay, and we are telling you as a lung ultrasonologist squared sign. So here we are telling you a boundary where the fluid has split because of fluid, and we are telling you about the sinusoid sign because the lung is freely moving in the fluid. Now, depending on the character of the fluid, you can sometimes guess what it is. So, a fluid which is hypoechoic like this is likely that it could be a transudative kind of fluid. A fluid which is hyperechoic, okay, it's you see that fluid is white kind of fluid here, hyperechoic fluid that might be, or you have many echogenic contents here that kind could be either pus or it could be blood. So sometimes the fluid can give you the idea about how it is. In lung abscess, you will have the destruction of the parenchyma. So it will be more like a well-defined area which will be in the parenchyma. You will not find this kind of picture in lung abscess. So destruction of parenchyma by a well-defined kind of thing would be more like a lung abscess.
So another question by Dr. Pushpa: how to differentiate confluent B lines for Merlin space?
Okay, so I see the concept of confluent B lines was again the confluent B lines, the compact B lines. So these concepts were given by some of the neonatologists like Raimondi and De Luca. So we don't use those nomenclatures as a CURF when we're trained in Paris. So for us, they were not there. So what people have done, they have called the lung rockets like this as confluent B lines. So where there are spared spaces, okay. And what they have done that when it is totally echogenically, it is white, where there are no spared spaces. People have called it as compact B lines. So we don't use those terms. Merlin space is the space below the pleural line. Okay, below the pleural line, this space is the Merlin space. And the Merlin space, you are doing the lung ultrasound correctly when your gain is right. So what is the correct gain? So correct gain is what? Let me show you what how it is so important. Okay, so correct gain is when you see the ribs and the echogenic shadows. The echogenic shadows should be dark. They should be dark. And you are seeing a echogenic pleural line and you are seeing a grayish Merlin space. Okay. So if your Merlin space is appearing too bright, that means you have put the gain too much. So always do lung ultrasound with low gain. Even if there are B lines, they will appear. So keep the gain low, just as to keep the Merlin space grayish. And don't use too much of depth in newborn lung ultrasound. So here you see just depth is just 2.2 centimeters. So very less depth because lung is a superficial structure. So Merlin space should appear grayish when you start doing the lung ultrasound. Okay? And compact B lines will be that there are so many B lines in the Merlin space that the entire thing appears to be something white out like this. I hope I'm able to make the point.
Yep. There are many other questions, but I think so. We have already, uh,
Yeah.
almost 10 minutes, back,
Yeah, we have
we have to cover up because we have already lagging by 10 minutes. So
yes, sir.
thank you, Dr. Anup. If we'll get a time
Yeah.
after, because there is another session of this case presentation, then we can
Yes,
take
sir.
2 or 3 questions. Okay.
Sure, sir. Sure.
So before moving to the next session, I just want to share those who have just joined. There's announcement that we will be doing the neonatal lung ultrasound certified 3 months course from 9th May onwards. It is online and hybrid. In hybrid, you have 2 days of hands-on, level 3 NICU, physical hands-on training. And so if those who are interested can message, email, or for registration, you can scan this QR code. So now for the last session, that will be something very interesting because we have just picked, we will be discussing only a couple of questions. So for moderating this session and facilitate this session, one case will be presented by Dr. Sujit. Another case with very brief clinical history will be presented by Dr. Anup. So to facilitate this session, we have Dr. Kiran. So Dr. Kiran, are you there? You can see one Dr. Kiran Vakuli. Kiran More. Dr. Kiran More, are you there? Okay, it's fine. I don't think so. He's there. Okay, so Dr. Sujit, you can quickly present your case.
Yeah, sure.
In between, if something needs to be asked or something, I will just intervene just for the interest of the attendees. And if you have any question, anyone, you please write down in the chat box, and the support team, please copy and paste the questions which are being there in the other group, the participant group. Over to you, Dr. Sujit.
Am I audible and is my screen visible?
Yeah. Yes.
Yeah, so it's already 2 p.m., but still we are having so many doctors who are live. That means they are definitely interested in lung ultrasound. So in short, I'm going to present a very interesting case which we had in our NICU. So there was a 30-weeker preterm baby, 1.3 kg. And baby was put on mechanical ventilator, and the lungs were really bad. We had given surfactant also, and somehow we couldn't extubate the baby. Baby had severe RDS, and on day 6 of life, baby was still on ventilator support. And suddenly the baby deteriorated on day 6. So definitely we would think about many causes. So clinically, I thought of maybe there is dope. We have to see the dope as we all the time. Maybe there is some deterioration of the present clinical condition, or there was some obstruction, maybe some secretions, or the ventilator was not working well, or maybe there was some pneumothorax, or could be some PDA causing dysfunction in the baby. So then obviously immediately you go for a chest X-ray, and this is what we could see in chest X-ray. There was a right pneumothorax, and I've specially captured this X-ray so that I can show you all. But we could directly go for a lung ultrasound. So when we did a lung ultrasound, this is the picture what I got. Let's discuss this video. So let's start it in a stepwise. This is a skin, subcutaneous tissue, pectoralis muscle. These are the ribs: 1 rib, 2 rib, and 3 rib. Ideally, in one optimized image, somebody asked in the chat, how do you optimize image? So you should have your probe should be exactly perpendicular. There should be no tilt, no sweep. And at least 3 ribs should be visible. The gain should be good. The depth should be good. And there should be at least 2 intercostal spaces which are visible. So here I can see a bat wing sign, and here is the pleural line. So pleural line is regular, smooth, thick, hyper-echogenic, but I am not able to see the shimmery and like marching appearance in this video. I'm not sure if everyone could appreciate this, because this gradually comes with the experience when you keep doing multiple scans, and you can actually see how the lung sliding is. And then those who have been doing lung ultrasound can appreciate that there is no ant marching appearance. So the lung sliding is absent in this case. And you can see the A lines. This is one A line, two A lines, three A lines. So A line is present. A lines are present, but there is no lung sliding. This is called as A prime profile. We have different profiles with different clinical findings. What you get, the A prime profile, there is AB profile, there is A prime B prime profile. There are different profiles which you get in different pathological conditions. So in this video, we are having bat wing sign, and there's a regular pleural line, but the lung sliding is absent. A lines are present, but the B lines are absent. What do you do next? What do you do next? You put a M mode. Always put a M mode when you see that there is no lung sliding. So bat wing sign present, lung sliding absent, A line present, B lines absent. These are very characteristic features of pneumothorax. Then I put a M mode, and when I put a M mode, this line, this echogenic line, white line, is a pleural line. The structures above are seen as C, as I showed you in a normal M mode. We can see a seashore sign. So this is a C, which looks similar because there is no pathology in the superficial tissues. But the area below this is a Merlin space, which Dr. Anup was talking about. This space, the space below the pleural line, is called as Merlin space. So this should ideally, in a normal healthy lung, should look like a granular appearance, a sandy appearance, but it is not like that. Here you have a barcode sign, horizontal lines, which looks like a barcode. This is called a barcode sign or stratosphere sign. So this is classically seen in pneumothorax. So when I put in M mode, I could confirm that there is a pneumothorax. So just for a comparison, this is how a normal M mode looks. This is a motionless area. This is a normal lung, and here is a granular pattern. And in pneumothorax, you can see the motionless area is same, but the parenchyma in the Merlin space, when there is a positive motion, you will get a granular pattern, and because of the pneumothorax, there is no movement. So lung sliding is absent, and you get a barcode sign. There are what we have seen in a case of complete pneumothorax, the sensitivity is 100% of lung ultrasound and specificity is 95%. And in an occult pneumothorax, it is 79 sensitivity, 79% and 100% specific. So there are few more signs which we need to find when you are doing a lung ultrasound for a suspecting pneumothorax, like lung point. Dr. Anup has explained you in a very well way. That is a demarcation point between a normal pleural sliding and an area where the pleural sliding is absent, because there is air between the pleural and the visceral pleura. So I want to highlight and emphasize that there is presence of lung in this case of pneumothorax. You should have a lung point. I couldn't capture, but Dr. Anup has shown you. There is a profile. And in my case, there was disappearance of lung sliding. There was A line sign. There was disappearance of B lines. There is presence of pleural line and A lines. There is absence of lung pulse. It is little difficult to cover that, but in pneumothorax, absence of lung pulse is again a pathognomic finding. And when you put a M mode, you can see the barcode sign. There is actually a way to report the lung ultrasound whenever the way you report echocardiography. There is a performer to report ultrasound findings in pneumothorax also. You can just don't randomly write A lines present or B lines present or confluent B lines. There's a full performer which we'll be teaching you in our long course. So I just wanted to emphasize how a pneumothorax case looks like. Right.
Okay, thank you, Dr. Suji. That was very precise and very nicely encrypts all the signs of pneumothorax. So you have already answered the sensitivity is pretty high. So in this, you told that you have taken the X-ray only just to Sure, but if you don't, if you are okay with good with the lung ultrasound, so it is good that we directly do the lung ultrasound and we diagnose the pneumothorax and we can act on it.
Yes, definitely, because pneumothorax is an emergency. My baby is deteriorating. An X-ray will definitely take me 10 to 15 minutes for the technician to come and do the X-ray, and it takes time. So if I have my probe, I have my ultrasound machine, hardly it will take me 1 to 1.5 minutes to get the lung point and do a M mode and get the diagnosis and drain it. So that would be very useful for the management point of view.
There is another question, like, is it possible to differentiate tension pneumothorax from non-tension pneumothorax? The accumulation of the air is less or more.
There
Anything?
is nothing to quantify how much air is there, but yes, when the lung point is a classical finding. If your lung point has gone all the way to your axillary area, very laterally, the more lateral the lung point you find, it means that the pneumothorax is very severe.
Great.
Right.
Fine.
Any more questions?
So thank you. There are other questions, but the thing is, we don't have time. It's already
Right.
2023.
I'm sure
It's 2:23.
everyone must be hungry.
So yes. So we'll switch. We'll go to Dr. Anu for the case, and Kiran has just joined. I think so. I don't know. Hello, Dr. Kiran.
No, I was there listening throughout, just got distracted somewhere in between. Very nice session, actually. I don't know whether we can, I mean, there are a few more, I mean, questions are coming, but we discussed most of the things. So really excellent sessions today. So this empyema and pleural effusion, that question, did we discuss?
Yeah, we
Yeah, we
discussed.
did discuss. Yes, yes.
Yeah, we discussed. No, sorry, I missed that one. Yeah,
Yeah.
perfect. So I think rest all is pretty good.
Yeah. So we quickly go to Dr. Anup, and
Yeah,
because
so
we have already 2024.
yeah, Sujit, you can just stop sharing. I will just we'll just finish the quick in 5 minutes and we can finish. Okay, so last 5 minutes maybe because I skipped the lung scoring part, and that is very important for all of you because lung scores are coming a big way in highly membrane disease to give surfactant for prediction of bronchopulmonary dysplasia, lung fluid extubation, lung scores for shock, lung scores for PDA. So there are myriads of people, and you need to understand what is the concept of lung scores. So this is a case which I'm presenting to you. This is a primary care beta mother with history of PPROM and delivers 26 weeks baby vaginally. Baby was smallish and required some positive pressure ventilation at birth. Is intubated. Birth weight is 600 gram. So I will take it forward because there's less time now. Otherwise, I would have quizzed you all and asked you what is there. So you see here, these are the ribs here, okay, and these are the shadow of the ribs, okay, and these are the black shadow of the ribs, and this is one Merlin space, this another Merlin space. Look at the pleura closely. Now the pleura here appears, normally the pleura is a sharp and echogenic, well-defined pleural line. So here the pleura is not that sharp, not well-defined. It appears to be thickened. The pleura is thickened. And you see in the entire Merlin space, which should be grayish, there are multiple B lines which have joined together to make the entire Merlin space as a whiteout pattern, which we call the Birulu variant or the Stotty variant. And the entire space is whiteout in all this. And if you look closely, just below the pleural line area, you find multiple echogenic dots here. Multiple echogenic dots. These are nothing but these are subpleural consolidation. These are subpleural consolidation. Now, just a minute. Just a minute. Just one. Yeah, sorry, there was a call by one of our colleagues. Okay, so you see here, based on this, can some of you tell me what is the pattern which you are seeing here right now? The pattern. We
Just
discuss abnormal. Yeah, just type. Okay, if you can type, it's fine. Okay, I'm proceeding from here. So this baby, what is the clinical setting? What this baby is likely to have? Most likely, this baby is likely to have a surfactant deficiency, and this is the lung ultrasound of the baby. Now, we need to answer these three questions based on lung ultrasound alone without the need of any other test. What is your diagnosis? What is the next line of intervention? How it is based? And how can I wean this patient by lung ultrasound? So, going by the diagnosis, we saw that the lung ultrasound had the pattern both of interstitial syndrome and consolidation, some subpleural consolidation in a premature baby, 600 gram just born, and there were no shed sign there. So it is most likely interstitial pattern and some consolidation, which is produced because of hyaline membrane disease or surfactant deficiency. So that's our diagnosis. Now, can we decide our line of intervention based on that, and how is that based? So this is the section which I have not touched upon in the last class. So lung aeration, I told you that the degree of lung aeration you can quantify. So there could be just A lines, one or two B lines could be there, which is normal. Multiple B lines or lung rockets, this is abnormal, and that means there is lung aeration is decreased. And further, when the lung aeration decreases, you have more and more B lines, the ground glass rockets, you have the Biruli variant, the whiteout pattern, and you have shed sign. So this is how the lung aeration is decreasing, and these is the pattern which could be scored by a scoring system, and we can derive lung ultrasound scores, and we know how severe is the pathology, and we can also decide our intervention. Now, Dr. Mohit told you how to divide the areas into zones. So there are anterior, lateral, and posterior zones, three on each side. So total of 6 zones. So you have to do the lung ultrasound scan in each zone to provide a score. So anterior, lateral, and posterior. Some people, so three on each side, total of 6 zones is where you need to score the lung ultrasound. Now, what can happen? Sometimes some people don't use the posterior zone because they need to turn the baby or disturb the baby. So divided the interior into upper anterior and lower anterior and lateral. So again, three on each sides. So total of 12 zones. Okay, there could be other variations like 12 zone, 8 zone, or so on. But for lung ultrasound scoring, classically, all the authors have scored it in the 6 zone schemes for giving surfactant. And when you do the lung ultrasound in each zone, so if there's a pattern where this lung sliding is present and you have a pattern of A lines or maybe just one or two B lines, then it is a score of 0 because that's a normal lung. The lung is well aerated. Now, when you have some pattern like this, okay, so you have three or more B lines in between two ribs, the score is 1. And when you have crowded, compact B lines, so many B lines that entire Merlin space appears to be white out, and you see there are along sometimes there could be also subpleural consolidations also here. So crowded or compact B lines with or without subpleural consolidation is a score of 2. And if there is extensive consolidation, okay, extensive consolidation where you find almost like a shred sign, then the score is of 3. So like this, you can score the lung ultrasound. And so the maximum score is 3. And I told you that there are 6 zones, so 3 on each side. Okay, so 6 into 3, the total score, the total maximum score to score the lung is 18. So out of 18, you will score. And so let's score this patient, our conventional patient, if someone can score this. This got stuck, I think. This got stuck. Yeah, this got stuck. Okay, so we can just score this patient which we had. So this was the finding on all the 6 zone. So what do you think is the score? You can type in the chat box.
So many are saying 12.
Yeah, so excellent. So 12, because this particular score is of 2 when there is whiteout pattern along with subpleural consolidation, the score is 12. Total score for this patient is 12. And what people have done, so there are a lot of studies which have been done, like the Easter study, the Ultrasurf study, and right now last piece under which is the lung study, where people have given surfactant based on lung ultrasound score. So when the lung ultrasound score is more than 8 or the FIO2 is more than 0.3, so people have given surfactant, and it is one of the criteria which has been given by the European Association that lung ultrasound scores could also be used to give surfactant. So the idea was just to teach you the score, and this scoring system has also been used for bronchopulmonary dysplasia prediction, to wean the patients off ventilator, to extubate the patients, to diagnose PDA, in shock during fluid therapy. So these are the various kind of variation which have been used. I think that should be all. The slides are not moving, but we can just conclude here. That should be okay.
Great, Dr. Anup. That was really, like, this one concept needs to go into everybody's head, and that is how very aptly you have shown that. Thank you very much, Dr. Kiran. Any comments?
So I think excellent talk, Dr. Anup. It's always nice to listen to you. Always new learning, even after scanning for 10 years. I think you teach with a lot of passion, and same Dr. Surjit and Mohit. So great. I think we've covered most of the situation, most of the clinical scenarios which we commonly encounter for lung ultrasound. Uh, I'm not able to see all the questions, so mostly we have answered. Mm, so lung
Oh,
scoring.
they actually, it is coming in, it's going moving up, because he is, the sports staff is also, copying and posting, but now it's already 2:33.
Yeah.
So
Decision for
it won't be
surfactant, I think.
possible.
Decision for surfactant, I think in your unit protocol, you can make a protocol like many places follow more than, I think, 8. Dr. Anup, I don't know, more than 8 score you consider surfactant in your unit. So that's
Yes.
something.
I mean, we are still a very conventional unit, difficult to move around. So we are in the trial form right now, doing 2 studies on lung scans. But yes, 8 is the number which most people have taken. And even the study I was mentioning called the lung study, it is recruiting 700 babies, extremely low birth weight babies, and the score is
Oh.
8 is taken as a cutoff. So that is a huge study, and that will give the answer whether this scoring system versus the FiO2 can help us to decrease bronchopulmonary dysplasia. So that's a wonderful study which is being done actually.
So I just have one question, and many people they may be having this question. So, and there are papers on this also. What we have seen is when we do the lung scoring, the score will be 10. Okay, but the baby is on CPAP of 5 or 6 with FiO2 of 21%. So, as per the clinical indication, does not qualify for giving surfactant. But with a score of 10, like anything more than 8, or some studies says 10, it qualifies to give the surfactant. So what should be our approach in that?
Sir, see, right now we are going by evidence. I mean, we all are totally enchanted and fascinated by lung ultrasound. Lung ultrasound is so easy to actually pick up and learn that people are going right and left. So, whatever studies I have quoted in literature, whether it is the Esther trial, whether it is the UltraSurf trial, so one limb is FiO2, 0.3, 30% they give. Other limb is either. So, either lung ultrasound score of 8 or FiO2 of 0.3. So, people have given surfactant if when the FiO2 was less than 30% in that particular limb. Now, what they have found that when you give surfactant in this particular fashion using the lung ultrasound score, you have lesser duration of ventilation in that particular limb. They have better oxygenation. That is what people have found, and the overall surfactant like needs they don't go up. So that is again, this is a very relevant question, and that is the only way people have handled it. And obviously, as you rightly said, Dr. Mohit, that this might lead to overuse of surfactant just by using lung ultrasound score, and that should also not happen. Getting so enthusiastic with lung ultrasound.
So yeah, so great. It was great to have you all, and it was really nice that we had 925 participants were max. We could they were there and
Just
at one point of time. So that is something
just
which is really great. Yes, please.
Just one comment before you make announcement. Yeah. So, I mean, I can see the lot of resident fellows are enthusiastic, and as the lung ultrasound use is evolving, we had also planned some studies when I was in Doha, and some of them are ongoing. So now I think lung ultrasound can be used for knowing the recruitment or predicting the success of extubation or need of NIV or need of CPAP, because how the lungs are before extubating or on NIV. So you can even sort of prognosticate, or if you do serial lung ultrasounds, how to wean from NIV to CPAP, those kind of things, I think it might be useful. So for future research, those kind of questions one can explore, whether, you can come up with scores predicting the success of extubation or failure of extubation, all those things. And also BPD is something, again, a great lot can be done in severe BPDs, those kind of patterns we can predict. So a lot of studies can be planned in India, especially bigger centers. They should utilize lung ultrasound for, as a thesis projects for, for the fellows or the TMP. So that will be a suggestion. But great session today. That's it from my side. Over to you, Dr. Mohit.
Thank you, everyone. Thank you very much. There are a lot of questions and there are very detailed questions. It's very difficult to cover everything in 2 hours or 2 hours, 15 minutes. So that's why we have been coming up with 3 months, because all these things has to be discussed in some time. So, and Dr. Anup took one name, D. Luca, and hopefully he will be a part of this course as a guest faculty. So that whole things in detail, your all questions who are really interested can be answered in this 3 month certified course. And it is online for the people who really want to have an hands-on in unit, can opt for the hybrid one. So they will have 2 days in-house in the unit in level 3. So for the hands-on training, and if you are interested, you can register by scanning this QR code, or for any inquiries or WhatsApp number and inquiry number you have got, and the email is there. So you can always send us a message. And there is a YouTube NEFCO channel. Basically, till now there are only the eco ultrasounds and videos are there. You can follow us and subscribe to the YouTube channel. There are very small videos are there with the teaching videos, all concentrated to the echo till now. But soon, with this coming up courses and all, we will be able to upload the teaching videos for the lung ultrasound also there. And your recording of the whole CME will be available to you in the next 1 week. So that will also be uploaded on YouTube channel of NEFCO, and then we will share the link with all of you. And in the end, I would like to thank every one of you who have participated, and special thanks to Dr. Anuj, Dr. Anup Thakur, who is there with us, who has taken such nice sessions, along with Dr. Surjit, who was there with us to enlighten us on this lung ultrasound. And we both, as the host, Dr. Kiran and myself, are thankful. And we are really thankful to the whole sports staff and CIPLA. And Kanchan is there from CIPLA. We're really thankful to them for providing us this platform. As our own platform could accommodate only 100. And our registrations were around 1800 till we stopped the registration form. So that's why we have taken the services of CIPLA, and they were very kind to give us the services. And staff very much. And we will close the session here. Thank you very much, everyone.
One question people
Thank
are
you,
asking.
Dr. Noop, Dr. Sujit, Dr. Kiran.
Yeah, thank you. Just I think you can go to NEFCO YouTube channel only for the recording of this link. But if possible, those who have attended, we'll try to share the link for the recording in your email. So you can, we will send you that. Okay. Thank you.
Thank you.
It is
Thank you, Dr.
amazing
Mohit.
that,
Thank you.
almost
Thank you.
thousand of the doctors have
Yes.
been present to see to learn
Almost
the
1,000.
CME.
Close to 1,000.
Amazing. And the queries which I'm seeing, like they are really interested in knowing the lung ultrasound in detail. They are really interested, and definitely will try to clear all the doubts, maybe in the group or in the next course.
Sure. Thank you, Anup, and Surjit.
Thank you, Dr. Mohit. Thank you, Dr. Kiran. Thank you, Sujit. Lovely. Thank you so much.
All the delegates to staying till end. Thank you.
Yeah.
Bye-bye.